Good evening, everybody, and also hello, John.
Yes, hello, Andy. Again, how are you doing?
I'm good. I'm good. Thank you for taking time on Sunday to talk to us today. Would you like to start by giving us a little bit of background?
Yeah, go. Yeah, I started taking care of people with SMA who were using ventilators in 1977 in a facility that had a lot of iron lungs, and there were patients there with SMA and also muscular dystrophy and polio who were using non-invasive means of ventilatory support. So I started seeing them in 1977. And I've been a director or co-director of a Muscular Dystrophy Association clinic. That's a neuromuscular disease clinic for my university. I went to medical school at this Rutgers University in the 70s. And I've been working here as an attending since 1983. So, and all this time I've been in the neuromuscular disease clinic and have been taking care of people with neuromuscular conditions. SMA is very interesting. I want to get right to the information here. So I'm going to talk about SMA 1 through 4. But first of all, I want you to understand something. What is NIV? Now, in English, we use the abbreviation NIV. That stands for non-invasive ventilation. You can look up a lot of articles on NIV, and they all refer to CPAP, which is continuous positive airway pressure. Now, CPAP is a continuous flow of air that goes through the nose and keeps your throat open so that people with obstructive apneas during sleep, they can keep their airway open and use their muscles to breathe. It's essentially useless for anybody with weak muscles, but that is NIV. NIV refers to CPAP. Nobody with SMA really ever needs CPAP. Now, but it also then refers to something called BiPAP. A BiPAP is a bi-level positive airway pressure. Now that's the same as CPAP, except that you can get a little extra pressure when you inhale. Now, of course, it's the pressure when you inhale that's important, because that's what helps you get a deeper breath. The sleep doctors that do polysomnographies, they titrate away the apneas and hypopneas by adjusting bi-level pressures. And they prescribe bi-level machines. Now, bi-level machines are cheaper than portable ventilators, but they are ventilators. They can be used as ventilators, but I don't want to get too complicated. But the fact is that whenever you see the abbreviation NIV for non-invasive ventilation, it always refers to CPAP, or I should say almost always refers to CPAP or bi-level PAP, but unfortunately low span bi-level PAP. Now, what do I mean by low span? Well, the span is what helps us get a deeper breath. It's the difference between the air coming at you when you inhale and the air coming at you to stop you from exhaling. Nobody needs air coming at you to stop you from exhaling. It's like exhaling with the head your head out of a window of a car going maybe 60 miles an hour. It doesn't do you any good. Why do they have it there? Because people with obstructive apneas, old people who snore and have obstructive apneas, just need CPAP to keep their airway open and they can breathe. But that's not the case for people with weak muscles. For people with weak muscles, as I mentioned, CPAP is useless. Now, bi-level PAP can be helpful if you give a good span. So in other words, if I get hit by a truck and become a C1 quadriplegic, if I have no muscles below my neck at all, zero, I have 0 milliliters of vital capacity. Now, vital capacity is the deepest breath you can take, the volume of the deepest breath you can take. If it's 0, it means you can't breathe at all. It means you don't have any muscles to breathe with at all. So let's say that my vital capacity is 0. Now, to give me a breath to keep me alive, I would need either 600 milliliters of air, which would create a pressure of 18 centimeters of water in my lung, or you could give me a pressure of 18 centimeters of water, which would give me about 600 milliliters in my lungs. So whether you set a machine to deliver volume or pressure, the end result is basically the same. You could provide full ventilatory support by giving a pressure of about 18 centimeters of water or the volume that that would create. Okay, now I hope that's not too complicated. Again, EPAP or air coming at you to stop you from exhaling does absolutely no good for people with weak muscles. Does it help anybody? Yeah, as I mentioned, if you're old and you snore and you have obstructive apneas alone, if you have chronic lung disease, you have air trapping, you can't exhale fully, and the expiratory pressure has some benefit. And if you have a tracheostomy tube, a little bit of expiratory pressure compensates for the subglottic pressure that is lost because of the tracheostomy tube. So EPAP, or what we call PEEP, EPAP and PEEP are the same thing. You may have heard the term PEEP, but probably not. You probably have heard the term EPAP because most people use BiPAP. So the EPAP can be helpful for certain people, but not for people who have weak muscles. So I want to make that clear. So when people mention NIV, or non-invasive ventilation, they say many of the benefits of CPAP and low span BiPAP. And the benefits are for people with mild muscle weakness to improve their symptoms and get rid of their obstructive apneas and hypopneas and all of that. But if somebody is very weak, low spans of BiPAP. Now, again, what is a low span? Well, BiPAP is usually prescribed at a span of like 8 centimeters of water inspiratory pressure, or IPAP.
Hi, John. Just to interrupt, I think your screensaver might have kicked on your PC because we've got a blank screen.
Excuse me? You have a blank screen?
We've got a blank screen at the moment.
You don't see the NIV?
No. Has your screensaver come on or anything like that?
No, nothing has changed. I see it all. It says you are screen sharing. And I still see, I didn't touch my computer. It says,
just try try unsharing and sharing again.
All right. I did. Let's see.
Gotta love technology.
Yeah, it's just, I've had a nightmare this week. Okay, I'm going to say stop sharing. Okay.
Okay.
And now I'm going to click on share screen again. Do you see anything?
Yeah, there we go. You're back. So now if we go to, if you do your F5.
I'm trying. I'm clicking on F5 and nothing's happening.
You go to.
Okay, there we go.
There you go. There you go. Great.
So, okay. So the so-called bi-level positive airway pressure is usually prescribed at about 10 centimeters of water pressure going in, and then 4 or 5 stopping you from exhaling, the EPAP. Now that span is 10 minus 4 or 6. 6 is what gives you a deeper breath, a slightly deeper breath. But it's not a deep enough breath to rest your muscles or to ventilate patients who have practically no ability to breathe. Now, when people begin non-invasive ventilation, you could begin with this low span BiPAP and you'll do okay. But if you get a cold and you need deeper breaths, it won't save you. You'll end up getting intubated, going into respiratory failure, and then having 10 doctors tell you you need a tracheostomy tube.
John, it stopped again.
It did. So if I say stop share and then go back to share again, stop share, and then share screen, does it pop back on?
Not yet.
No?
Try stopping sharing again.
Okay. All right. Stop share. It's taking time to stop sharing. Okay.
Right. Okay.
It says Zoom quit unexpectedly. Meeting is now streaming live. Join audio, share screen. I'll click share screen. See anything?
Not yet. This is extremely annoying. Let me just. Right, let me share. Sorry, everybody, for the slight interlude.
Oh, I've had a nightmare this week with digital problems.
No, technology does my head in.
Yeah.
I'm just going to share the screen myself. All right, so that's now shared the screen. My screen.
Tell me if you want me to click on something.
Yeah, just click on share screen again.
Well, it says you are viewing Andy Thornton's screen.
Yeah, but if you scroll.
Join the meeting. How about join the meeting?
No, go to the top of the screen where you get the drop down box.
Well, I don't. Let me see. It says view options. There's a drop down box there. No, I don't know if that's good.
Have you not got your share screen button?
Well, no, there's no share screen button there.
Okay, let's me stop sharing and see if that helps. Have you got your share screen button now?
Yeah, share screen.
Right,
okay.
So try again.
Okay.
Someone's suggesting in the chat.
It says here, screen sharing has stopped as the shared window is closed. That's what it says.
Okay, shouldn't be, because I've got, hold on. Right, okay, stop. So someone in the chat room is suggesting maybe try it not going into presentation mode. So maybe that is the issue. So I can see your screen at the moment. So if you start, so if you start your PowerPoint.
All right, let me try that.
Go back to your PowerPoint, but don't press F5. Don't go.
All right, let me.
It's at the bottom of your screen. Right the way down the bottom. Left a bit.
The PowerPoint. Oh, there it is. Yes.
There it is.
Now, can you see that?
We can. So it might be better off just doing it full screen and
just. All right. That's fine. As long as you can see it.
Not like that. Press escape, because I think that might be what's causing the problem. Or come out of that and just run the PowerPoint like that. Is that okay?
Yeah, it's okay with me. That's fine.
Yeah, I think that's going to be easier because someone's suggesting presentation can sometimes cause some issues.
Ooh, all right. So you can see that. What is NIV, right?
Yeah. Okay.
So just to summarize what I just said, if someone wants to rest your muscles, first of all, as a physiatrist, a muscle doctor, one of our key principles is to rest muscles and exercise them. If you want to make muscles stronger, you don't wear them out by making them work partially, because that sort of wears them out. What you want to do is you want to rest them as fully as possible and then exercise them. So the way to do that is to provide the entire breath. If you want to provide an entire breath, you've normally got to give it at 18 centimeters of water pressure. So if you have BiPAP, you can do that by setting the inspiratory pressure to 22 and the EPAP to 4, because that's 22 minus 4 or 18. Now I don't use BiPAP, I use 18 and 0 because it's more comfortable and it makes more sense. But you cannot do that with the BiPAP machine, because with BiPAP machines, you cannot turn the EPAP off. But the important thing here is the principle. The principle is that NIV is never used at non-invasive ventilatory support settings. It's just not done that way, almost anywhere, except on the centers that are on our website, which I'll talk about later on, breathenvs.com, because these centers understand this idea, and nobody else seems to. The sleep doctors don't, because again, they use low spans to titrate away apneas and hypopneas, but they don't monitor the carbon dioxide to normalize the ventilation. Now, what I said there was a little bit complicated, but I guess I'll get a chance to go into that further later on. The important thing here is that when you hear the term NIV, it's usually inadequate. No article on NIV ever says that it can be used for respiratory support, ventilatory support. Yet, I've known since 1977 that you can use non-invasive ventilatory support without tracheostomy tubes. So that NIV is CPAP and low span BiPAP. So what is NVS? Non-invasive ventilatory support. Well, as I mentioned, it's a full breath. It's either a pressure of about 18 centimeters of water or a volume that can give you a full volume at the full pressure of 18 centimeters of water. Now, I always prescribe for my adult patients 800 to 1500 milliliters. And I let the patients decide what volume they want. They almost always want 1200. They might start at 700 to 800. They always end up at 1200. Now, they don't take every breath at 1200. They take some breaths at 1200 and other breaths they don't take at all. But the point is that it's extremely important to vary the tidal volumes. It's extremely important to vary the breath volumes. There are many reasons for that have been written about, and I have written about them. So NVS, now can BiPAP be used for NVS? Of course, if you use it at 22 and 4. That's basically NVS settings, okay? But whenever you hear the term NIV, you must be suspicious that it's a doctor who doesn't understand non-invasive ventilatory support, and the patients end up going into respiratory failure and end up either dying prematurely or getting tracheostomy tubes. So there are three aspects of management. One is long-term non-invasive management. But even with using NVS and the cough assist, which is mechanical insufflation exsufflation, basically you can think of the cough assist as a vacuum cleaner. You put the thing over the nose and mouth and all the secretions come out of the airways, and it's needed for people whose cough is too weak to do that. In fact, you should never even talk about NIV or NVS without talking about MIE, mechanical insufflation exsufflation. That is the cough assist. The reason that my SMA1s have been continuously vent dependent since as young as 4 months of age and are now over 26 years of age, and none of them have tracheostomy tubes, is not just because of NVS, it's also just as much because of MIE, the cough assist or mechanical insufflation exsufflation. They would never have gone 25 years and probably another 25 without the cough assist. So long-term management involves NVS and the cough assist. But even with the cough assist, it will eliminate 90% of pneumonias, but not 100%. When a patient gets a severe flu or a bronchitis and a pneumonia, and they need to be intubated, if you use optimal non-invasive ventilatory support and MIE, the cough assist, and you still get pneumonia, then you need to be intubated. And you will be ventilator unweanable, quite possibly. So in other words, when you're intubated with a tube down your throat, through the nose and mouth and into the windpipe, you will get so weak, you were probably already quite weak from being sick, but when you're in the hospital, you get weaker very quickly. And you get far too weak to breathe. So the doctors think that they can't take the tube out without sticking a tube through your neck. That's a tracheostomy tube. It is wrong. It is always wrong. But the critical care doctors simply haven't learned how to extubate ventilator unweanable people. Now, I've written books about it. I have 2 big articles on it. But critical care doctors are very busy. They don't necessarily want to learn how to extubate ventilator unweanable people. They're used to putting tracheostomy tubes in people, and they sort of like to just continue to do what they've always done. But I'm telling you that nobody with SMA 1, 2, 3, or 4 should ever need a tracheostomy tube because of being too weak to breathe. If you get cancer in your throat, that's a different matter. A fixed obstruction is a different matter, but not because of being too weak to breathe or cough. Now, when you do get a trach tube, what about taking the tube out? That's called decannulation. I've taken the trach tubes out of lots of patients, ventilator unweanable patients. However, I won't take the trach tube out of a ventilator dependent patient with SMA type 1, less than 12 years of age, because they panic. They don't understand, and it's really not possible. Plus, the trach tube can cause so much damage to the airway that it can be impossible to take the tube out after a period of time. It's so much easier to extubate a ventilator unweanable patient than it is to take the trach tube out of a ventilator unweanable patient. That anyone who's intubated for respiratory failure, I suggest you get copies of my articles, give them to your critical care doctors. Since they speak a sort of dialect of English over there, they can call me and I can discuss it with them. we can try our language skills. And, you know, I've taught intensive care doctors through extubating unweanable people, but they have to be willing to learn something and willing to do it. Some of the young ones are, many aren't. They just want to, you know, do their thing, and that's that. And that's unfortunate for the patients, because the tracheostomy tube has, see, the doctors who put in the trach tubes don't take care of the patients after that. I'm completing an update of my last book, which was 2004. And in a couple of months, this book will be done. It has 2 chapters on complications of tracheotomies. The majority of people with SMA who die because of respiratory problems die because of complications of trach tubes and invasive intubation. This book will be, I'll sell it for $30, and it will be full money back guarantee. My patients won't give up that book because of the 2 chapters on long-term complications of trachs, 2 chapters criticizing the so-called experts who let patients basically go into respiratory failure and get trached or die prematurely, and so on, because they don't learn how to use non-invasive ventilatory support continuously and properly use the cough assist. So I have 2 chapters criticizing them, and in a few months when I get this book finished and printed, it'll be on our website, and if anybody wants it, they can order it. But I guarantee that anybody who doesn't have a trach will never give up that book. It's, I hope you will see what I mean. Now, who does need a tracheostomy tube? Well, this is the interesting thing. Very few doctors take care of babies and old people, but I do. Now, the pulmonologists who take care of adults have patients with amyotrophic lateral sclerosis. I can tell you right now that the majority of them need trach tubes. And because they have very bad throat muscle function, what we call bulbar muscle function. I used to think that patients with spinal muscular atrophy who have no bulbar muscle function at all would also need tracheostomy tubes. Well, I will prove to you that they don't. But after a few years of this, I asked myself, how come my SMA patients don't need trach tubes, but my ALS patients do? And then it struck me that it has to be because ALS is an upper motor neuron disease and SMA is strictly lower motor neuron. And that is the answer. This is why that ALS patients do eventually need tracheostomy tubes and SMA patients never do, or they don't, they shouldn't. But it's not just SMA, it's also myopathy patients, muscular dystrophy patients, and so on. Only patients with spasticity that closes the upper airway and causes stridor need tracheostomy tubes, like patients with cerebral palsy, traumatic brain injury, stroke, and ALS, not patients with SMA. So when the older boy here, Mike, was an infant, I told his parents that if he did not get a tracheostomy tube, he'd be dead within 1 year. Now, his mom got pregnant again and had another child who is equally severe, actually slightly more severe, ventilator dependent, 24 hours a day, nasal ventilation since 4 months of age. As you can see, this was 1990, and this is 2010, 2012, this is 2018, 2020. So these guys have 0 vital capacity and they have absolutely no muscle movement at all, except they can move their eyes a couple of millimeters. Now with that, they're able to operate their computers, and they graduated high school, they go to college, and just by using their eyes and using their environmental control systems, and now they're going to learn how to operate their motorized wheelchairs using their eyes. But the point is that 25 years ago, I told the parents of these boys that they could not survive without a tracheostomy tube. But these are not my only ones. Now, this is another boy with typical SMA type 1. These boys are in the 10% of the most severe SMA type 1s because they were vent dependent 24 hours a day before 5 months of age. But this boy was not vent dependent for well over a year. In fact, hasn't been 24-hour vent user until maybe 15 years ago. Even today, at the age of 26, he can speak. and be understood to a degree. But he operates his motorized wheelchair, and again, I'll show you him. But I told his parents in 1995 that he'd be dead within 1 year without a tracheostomy tube also. So there he is trick-or-treating with his brothers and sisters, and we put him in the hospital when he was 16 and a half because he had a severe bronchitis and his parents were exhausted using the cough assist on him. So we intubated him for 1 day, let him sleep 24 hours, and then we extubated him and sent him back home the next day. This is after we extubated him at the age of 16 and a half. That was 10 years ago. Now he's 26 years old. And we have over 70 SMA1s who are 24-hour nasal ventilation dependent. Now, this is a girl who is also SMA type 1, and she's 26 years old now also. None of these patients have tracheostomy tubes. By the way, I want to point something out that's very curious, very interesting. If you could look closely, these boys have NG tubes, nasogastric tubes. They've gotten all of their nutrition through these nasogastric tubes since 4 months of age. When they were 4 months old, I told their mother, well, again, the second boy wasn't alive at that point, but I told the mother that they really should get, a gastrostomy tube. But she refused. I mean, she didn't want the trach tube. She doesn't want a gastrostomy tube. And they still have NG tubes after 26 years, no, 25 years. Okay. Now, you would normally think that would interfere with the nasal ventilation. It doesn't, and they don't even notice the tubes. They've had them all their lives. And this girl has a gastrostomy tube. All patients with SMA type 1 need gastrostomy tubes. And now she's 26. This little fella was transferred to us from Florida about 6 months ago. Also unweanable. They wanted to trach him down there. He failed 2 extubation attempts. We extubated him and sent him back to Florida, and mom sent us this recent photo. The boy now has had nusinersen and Zolgensma, and he's clearly getting stronger. So how long can non-invasive ventilatory support be effective? Well, for SMA type 1, so far I've got 9 patients over 20 years of age, and they are undoubtedly going to live at least another 25 years, so indefinitely. Nobody with SMA type 1 ever needs a tracheostomy tube, and if they do get one, I'm pretty sure their prognosis is not nearly as good. With Duchenne muscular dystrophy, we've extubated 81 consecutive unweanable patients with Duchenne muscular dystrophy. It's much easier to manage them and extubate them to non-invasive ventilatory support than SMA type 1 because they're able to cooperate. They can grab a mouthpiece and get air that way. They can use nasal ventilation. Nobody with Duchenne or any other myopathy should ever need a tracheostomy tube. In post-polio, I now have 2 patients who've been using non-invasive ventilatory support 24 hours a day for 66 years, and many over 50 years. With ALS, now, ALS is upper motor neuron and lower motor neuron. When upper motor neuron predominates, the patients need trach tubes and do not become continuously dependent on non-invasive ventilatory support. However, patients who are predominantly lower motor neuron can go more than 10 years. 24-hour vent users without a trach tube. So that's just a rundown of some other common neuromuscular conditions. Nobody with any myopathic or muscular dystrophy type disease or lower motor neuron disease should ever need a tracheostomy tube. This woman's been using non-invasive ventilatory support like this for 66 years. No movement below the neck. She uses a lip seal at night, not nasal ventilation. Lip seals actually work better. And here's a man who used a lip seal at night for 52 years with 0 vital capacity. Another person, 66 years of 24-hour non-invasive ventilatory support, and 14 years, this is an ALS patient actually, using nasal ventilation to blow out his birthday candles. So there's 2 types of respiratory conditions. There's failure of lung disease or oxygenation, which is like COVID-19, and there's failure of ventilation. Doctors are used to treating failure of oxygenation because they give oxygen, and that can prolong the lives of patients with lung disease. However, if you give oxygen to a patient who's got weak muscles, the patient will be back in respiratory failure sooner than if you do nothing for that patient. And the worst prognosis is giving oxygen. Next to that is getting a trach, and next to that, of course, well, there isn't anything next to that. non-invasive ventilation, they can use that indefinitely. So I published this in 1998, that if you give oxygen to a patient with SMA or muscular dystrophy, they will be back in respiratory failure sooner than if you do nothing at all. And patients without trachs have fewer hospitalizations and pneumonias than patients with trachs, even when they're 24-hour event users. Not only does the oxygen turn off your desire to breathe, in other words, the oxygen basically tells the brain that you don't need to breathe so much anymore. So the carbon dioxide can go up, and it can go up by over 100 millimeters of mercury. To put this in perspective, if I walk into a vat of fermenting grapes where the carbon dioxide level is 200, I will stop breathing. Anybody would. High carbon dioxide turns off your breathing. You become CO2 narcotic, carbon dioxide narcosis, and you stop breathing. Normal carbon dioxide is about 40. Now, you add 100 to that, and patients become comatose and they stop breathing. And oxygen can do that. Anybody with elevated carbon dioxide, now doctors know this for chronic obstructive lung disease, but they don't apply this to people with neuromuscular disease. And this is a big, big, big problem because people with lung disease need oxygen, but people with muscle weakness, if you give them oxygen, they can stop breathing. So nobody should be at home on oxygen therapy unless they've signed a directive saying that they truly want to die. Because oxygen and morphine will not keep you alive if your muscles are weak and your carbon dioxide is high. You need non-invasive ventilatory support, NVS, not NIV. Now, pulmonary function testing. People tend to be sent to pulmonary function testing labs. This is virtually useless. Nothing that they do is designed for people with weak muscles, except for the simple vital capacity. Now, they do a vital capacity, a forced vital capacity, but they never do it with the patient lying down. But people underbreathe and their carbon dioxides first go up during sleep. So the most important vital capacity is the vital capacity with the patient lying down. But not only do they not study that, they don't study cough flows, they don't study carbon dioxide, they don't study the ability to expand the lungs, what we call lung volume recruitment. They don't teach you how to frog breathe and study that. It's useless. Pulmonary function testing is virtually useless. The vital capacity in the sitting position is the only thing of any use at all. Why is it done? Because physicians don't realize that patients with weak muscles need different tests. Also because in the United States, they can charge for this and get paid for it. Getting a simple vital capacity with a handheld spirometer, you can't charge for that. Bronchodilators and oxygen therapy, CPAP and BiPAP are for people with lung disease. They're not necessarily going to be any benefit for people with weak muscles. Oxygen therapy is particularly dangerous. Polysomnograms, that's what Americans get sent for because the sleep doctors basically treat everybody as though they have central or obstructive apneas, even if you're too weak to breathe. This is useless for people with SMA. First of all, any babies with SMA, all babies with SMA type 1, and 50% of those with SMA type 2 have paradoxical breathing. This means that when the belly goes out and they're inhaling, their chest muscles are not good and the chest sinks in. That's paradoxical breathing. Anybody with paradoxical breathing, if they're not put on NVS for sleep, their lungs will not grow, they will develop pectus excavatum, and they will not survive very long. Polysomnography is completely useless because every child with paradoxical breathing with neuromuscular weakness must be on nighttime NVS and not low-span BiPAP. What about older people? Polysomnography will tell you how many apneas and hypopneas you have, but if they're not measuring carbon dioxide, it's essentially useless. We measure oxygen saturation and carbon dioxide levels, and we've managed 3,100 patients with non-invasive ventilation without having to send any for polysomnograms or pulmonary function testing. So what's so bad about a tracheostomy tube anyway? Well, you know, it's a foreign body. There's always as much pathogenic bacterial contamination on that tube as anybody with acute pneumonia has in their lungs. And the reason that it's there is because, number one, there's no blood supply to the tube. So no matter what antibiotics you give to the patient, it doesn't have any effect on the pathogenic bacteria that are on that tube. And they just keep going into the lungs. And 17 to 65% of patients develop tracheal stenosis. That's where the trachea below the tube gets so narrow that air just can't get through anymore. And then, of course, we can't take the trach tube out of these people. And very often that's just before the trachea bursts and patients die. There are many, again, like I said, the majority of people with tracheostomy tubes on ventilation die because of the tracheostomy tubes, not really because of the diagnosis. They die directly because of the tubes and, of course, indirectly because of the diagnosis, but they also die because they don't really need the tube in the first place. In New Jersey, we would manage them without tubes. There's no doubt about that. So anybody with a trach tube has as much pathogenic bacteria in their lungs as anybody with acute pneumonia, and it's because of the tube. When we take those tubes out, now people with trach tubes, they always want a lot more air. So their carbon dioxide levels don't go up, they go down. This makes them more dependent on the ventilator. There are many reasons for people on trach ventilation to keep asking for more air. Many reasons, including the fact that we need to vary our breath volumes, and you can't do that on trach ventilation. But when we take the trachs out and we put the patients on non-invasive ventilation, their CO2s come up to normal, and they have more freedom from their ventilators. Also, invasive ventilation makes the diaphragm wither away. It gets atrophic, and it just becomes weaker. But there are many other reasons that people with trach tubes die. They die from hemorrhage, cardiac arrhythmias, the tube going into the esophagus, going against the skin, subcutaneous emphysema, mediastinal emphysema, nosocomial pneumonias, all these reasons. There are many reasons why people with tracheostomy tubes on ventilation die. 80% of these ALS patients died because of their tubes. More than 50% of patients with Duchenne muscular dystrophy die because of their tube. And without a trach tube, their average life expectancy is 10 years longer than with the trach tube. And the patients who don't have trach tubes almost always die because of a cardiomyopathy, because in muscular dystrophy, it can affect the heart. That does not generally happen in spinal muscular atrophy. That's why my SMA1s, who are vent dependent since 4 months of age, I expect them to live normal life expectancies, even though they have zero vital capacity since they were small children. So there are 3 respiratory muscle groups. There's the breathing muscles, the coughing muscles, expiratory, and the throat muscles, the bulbar innervated muscles, whose main job is to protect the airways. How do we evaluate patients? Number one, with their carbon dioxide level. This measures the carbon dioxide at the nose. It's painless and instantaneous. So when the patient comes to see me, I immediately know what his CO2 is. Again, they don't do this in pulmonary function testing. Oxygen saturation, a $10 peak flow meter that patients cough through. And the cough flow under 300 liters a minute is a problem. And a spirometer. This handheld spirometer gives me the information I need right away, but I use it for a lot more than measuring the vital capacity with the patient sitting there. This is a graph of what happens to your cough flows as the vital capacity goes below 40%. When the vital, a cough involves a deep breath, and then we generate pressure with our abdominal muscles, and then we open our throat, our glottis, and we cough. The first part of the cough is a deep breath to 2.3 liters of air. Now, a normal breath is 1/4 that. So we can have normal carbon dioxide, normal ventilation, and normal breaths, and still have a very weak cough because we can't get the 2.3 liters of air that we need for a good cough flow. But then too, if you have weak inspiratory muscles, you probably have weak abdominal muscles. And when the cough flow goes below 300, the risk of pneumonia increases. Below 200, almost any cold will end up causing pneumonia. So our treatment goals are lung volume recruitment. Now, what is lung volume recruitment? All right, I'll tell you. Lung volume recruitment is, let's say that your vital capacity is 40% of normal. This means that you're not putting any air in 60% of your lungs. Will it do any good to use an incentive spirometer where you take a deep breath and the little ball goes up? Absolutely not, because you cannot go beyond your vital capacity. It's impossible by definition. However, you need to put air in the other 60% of your lungs. Otherwise, the lungs get small and stiff. The only way you can do that is by active or passive lung volume recruitment. That's our first goal. Our second goal is to maximize cough flows. And our third goal is to maintain normal carbon dioxide around the clock. By the way, if you're sitting in a wheelchair all day, your knee probably gets stiff. You get a contracture of the knee. The same is true if you don't put air in half your lungs. If you don't put air in half your lungs, that half closes down. It becomes stiff and you lose that volume. The intercostal muscles get stiff and rigid and the whole chest wall gets small. Lung volume recruitment is very important. So how do we do it? Well, we use an ambu bag, a manual resuscitator. We deliver the air through a mouthpiece or a lip seal like this, or a nasal, or we deliver it through a nose piece like that until we can't get any more air into the lungs. And then the patient exhales the air into the spirometer. That's our maximum insufflation capacity. And the more that is greater than the vital capacity, the stronger your throat is. And really, that's very good. The deeper you can air stack, we call this air stacking, over your vital capacity, the healthier your lungs will be. Now, another way to do this, another way to do this is by frog breathing. I don't know, I don't think you can see me. I'm wearing a tie with frogs on it. Frogs do not have diaphragms, but they use their tongues to ventilate their lungs. So unfortunately, if you can't see me, then you have to get yourself a frog. I mean, if you've got dogs and cats at home, you probably never learned anything from them, so trade one of them in for a frog. Again, the frogs don't have diaphragms. Imitate a frog and you'll be able to ventilate your lungs without using a ventilator. In fact, I have patients who woke up at night, patients with zero vital capacity, who woke up at night frog breathing to discover that their ventilators were no longer working. Anybody being ventilated through a tracheostomy tube would have died because there were no alarms on the vents in those days. But you know, if you know how to frog breathe and do it well, you can frog breathe all day long. If I get hit by a truck and become a C1 quad and I have zero vital capacity, nobody will even have to intubate me because I can ventilate my lungs all day by frog breathing. It sounds like this. And that's what I do. Again, like I said, I can ventilate my lungs even if I have no muscles below my neck. This is a patient that who after the age of 40, his frog breathing ability went down. That's the line in the middle. Vital capacity is zero. The frog breathing ability was good until he was about 40, but then it went down because his throat muscles were getting weaker. But even so, he could still air stack to 1.6 liters. So that was keeping his lungs big and healthy. So when we air stack our patient there, the patient blows the air into the spirometer. Again, we call that the maximum insufflation capacity. That is the capacity by air stacking or active lung volume recruitment. This is a patient with a vital capacity of 900 milliliters, but she's able to go to 3 liters essentially by frog breathing. Now, why does she do that? Because this is lung volume recruitment that she can do without even using an ambu bag, without using a ventilator. Also, she can do it anytime, day or night, and that will give her a powerful cough. And with the deep breath, she can scream, she can yell, she can talk longer. She doesn't necessarily need to get help from anybody because she can get a deep breath and cough effectively by frog breathing. And this is a patient with zero vital capacity who's able to frog breathe all day long with normal minute ventilation without using a ventilator. Now understand, zero vital capacity means they're totally paralyzed below the neck, have no breathing muscles whatsoever. Could he do this with a trach tube? Of course not, because the air would leak right out the ostomy. Anybody with a trach tube is always frightened that the ventilator will fail or get accidentally disconnected. My patients are not afraid of that because 70% master frog breathing enough to be able to use it instead of their ventilators. Cough flows are very important. because that's why people go into respiratory failure. They don't go into acute respiratory failure because they can't breathe. They can't breathe because they can't cough, and their mucus plugs prevent them from breathing and they get short of breath. So mucus plugging can cause the lung to collapse in minutes. 90% of mortality in SMA is triggered by chest colds, where the patients go into respiratory failure. As I mentioned before, to cough effectively, you need a deep breath, then you need to generate pressure, and your glottis has to hold that pressure until you cough. And when we inflate the patient and press on the belly, we get an assisted cough flow. So how do we do it? We air stack our patient with the ambu bag or a ventilator. We press on the belly and we measure the cough flow, which is now, I don't know if you can see that little blue mark there. It's like 600, it's way, way up there. But the patient coughing on his own was much, much lower. So, I mean, this can greatly increase your cough flows. In fact, it increases them to the point where they become effective. And if you ask me to show one image that demonstrates why my patients virtually never need tracheostomy tubes, it would be this one. It's because with ineffective cough flows on the left, if you teach the patient manually assisted coughing on the right, with air stacking, the cough flows become effective, even without a cough assist. This is a cough assist. And in England, you've got the NIPI, which basically does the same thing. There are a couple of slight differences though. See, one of the things I like about the cough assist is that we can measure the expiratory flows. I don't think you can do that yet with the NIPI. At least I haven't been informed that they've modified the NIPI to be able to do that. Now, why is that important? Because the greater the flow that you get with MIE, the more open is the upper airway, and the more effective is the cough. The greater the cough flow, the more effective the cough, and the more effective the cough, obviously the patients won't need to be trached. Nobody ever needs to be trached because they have zero vital capacity. They can always use non-invasive ventilatory support provided they can cooperate with it, which is very simple. However, if you don't get your secretions out, you cannot use non-invasive ventilatory support. You won't survive. In fact, if I get a cold, a bronchitis, and I have airway secretions, and I do not cough at all, I'll be dead within 2 hours, maybe within 10 minutes. Coughing is a vital bodily function, like breathing. When I send articles to journals, they say, where's your control group? You cannot do a control group when your intervention replaces a bodily function that is critical to survive. Coughing is critical to survive, as is breathing. You can't match it with a placebo like aspirin. You must cough effectively or you will get pneumonia. Any cold will develop into pneumonia. Believe me, the academicians in the pulmonary journals don't understand that. And this is a small child, 2.5 years old, getting her trach tube out using the cough assist in Japan. Now, the cough assist or MIE or the NIPI is used wrong. It's used at inadequate pressures and inadequate frequencies. And the reason it's used badly is because in 1993, I put 3 articles on, I published 3 review articles that said that the cough assist was equivalent to the old coughlator that was on the market from 1953 to 1967. Now, the coughlator, which is identical essentially to the cough assist, except that the coughlator was, the units of flow were millimeters of mercury, and the cough assist, it's centimeters of water. That's the only difference. The patients who had coughlators would not give them up because they told me that if they didn't have the coughlator, they'd be dead or they would get trached and be, they would have to be intubated and they would get trached. That's what they told me. In 1988, 2 of my patients put an article in a newspaper begging somebody to put the coughlator back on the market. That was in September of '88. In October, November, I went to every ventilator manufacturer in the United States. Nobody paid any attention to me except for Mr. Jack H. Emerson. Mr. Emerson is the guy who put the iron lungs on the market in 1931. In 2 months, Jack Emerson gave me basically what became the cough assist. I immediately started using it in critical care. And it permitted me to routinely extubate ventilator unweanable people. And I will again show you this. But it was thanks to Jack Emerson. In fact, I dedicated my first book in 1996 to Jack Emerson. And I'm going to dedicate a chapter on the cough assist, on MIE, in the book I'm finishing now, to Jack Emerson also. He was 6'5", a very elegant man. He lived on Madison Avenue in New York City in the teens, 1915. And he was telling me all about what New York City was like at that time. He was quite a guy. So the second goal is to maintain normal alveolar ventilation around the clock. So who needs to use NVS for sleep? Any baby with paradoxical breathing. And normally when they have that, they also perspire, flush, they breathe quickly, and they awake frequently. If that rings a bell, it's in part or a large part because they're struggling to breathe and they're not being placed on NVS. For older patients, they will complain of morning headaches, fatigue, and daytime sleepiness. They can have decreased appetite, depression, impaired concentration, nightmares, many other symptoms. The indication for NVS is for babies and small children, paradoxical breathing, or symptoms of hypoventilation. Those are the only indications. Imaging of the diaphragm, even the vital capacity is not important. If your vital capacity is decreased and you have symptoms, you need nighttime ventilation. Many people cannot sleep lying down. That's called orthopnea. It's because their diaphragm's weak. But their vital capacity could be very good when they're sitting, but practically nothing when they're lying down. They go to pulmonologists and to pulmonary function testing labs. They don't even do the vital capacity lying down. So the diagnosis is missed completely. Anybody with decreased vital capacity who is symptomatic for the symptoms I mentioned should try nighttime non-invasive ventilatory support. And if it doesn't make you feel better, don't worry about it. We'll test you again next year. We'll check your carbon dioxide during sleep and your oxygen saturation, and maybe that will convince you to try to use it and get used to it. But nobody dies because they don't start non-invasive ventilatory support soon enough. People die because they're given oxygen and they stop breathing, or because they get an intercurrent respiratory tract infection and go into respiratory failure that's not managed properly with optimal non-invasive ventilatory support and optimal use of mechanical insufflation, exsufflation. And optimal use of that, I will still talk about. You got to use it at 50 to 60 centimeters of water, not less than 40. How do you begin non-invasive ventilation? Well, for babies, we let the moms put the babies on the nasal ventilation at home. We teach mom how to do it in our clinic. And we tell the moms that we want to see that when the belly goes out, the chest has to go out, not sink in. Remember, when the belly goes out and the chest sinks in, that's paradoxical breathing. That's what causes the lungs to not grow. We want, when the belly goes out, we want the chest to go out too. And it will if you put the patient on NVS settings, but you have to have a sleeping patient. So we teach mom exactly how to do it. For older patients, it's a question of symptoms. Now, if I'm not sure if you have symptoms or not, I will recommend an oximetry and end-tidal carbon dioxide monitoring in your home. And if your CO2 really goes up, that will maybe convince you and me that you have some symptoms and that you should try nighttime NVS. But like I said, if it's really inconvenient, you don't like it, and you're not getting as much benefit out of it as inconvenience from it, then we can check you again the next year. It's not, you know, if the CO2 is very high, carbon dioxide is acidic. It makes the rain acidic and it makes your blood acidic. After many years of that, you get strain on the right side of the heart and you can go into heart failure. So if you have any symptoms at all, we normally don't have to urge patients to use nasal ventilation, ventilatory support, because they feel better doing it. So if your vital capacity is low, then your diaphragm gets tired and the diaphragm can collapse and you can stop breathing. Well, the ventilator is like a pickup truck that rests the diaphragm overnight so that you're stronger during the day. And when you use nasal ventilatory support overnight, your blood gases during the daytime always become normal. I mean, always. It's amazing. Just by resting your muscles properly at night. I recommend against using BiPAP, although for third world countries like the United States, it's cheaper than a portable ventilator. It's not so good because you can't turn off the EPAP. The LTV ventilator is a very good one because it can only be used with an active circuit, which means you can always shut off any EPAP. You cannot really give EPAP on the LTV ventilator, which is why I like it, because I don't want my patients to get EPAP or BiPAP. The Trilogy is a good machine. I know that NIPI makes a good ventilator too. The NIPI people. Now this is a baby with SMA type 1. But now there are infant nasal interfaces on the market. But a long time ago, we took the Hudson CPAP prongs, put the prongs through a foam that covers the nasal bridge on an adult CPAP circuit, and we ventilated our babies that way. This is mouthpiece ventilation. Now, mouthpiece ventilation is interesting. It was first described in 1953. Talk about doctors being dense and not learning very quickly. This is just one example. In 1930s and 40s, patients who got polio and SMA and muscular dystrophy were placed in iron lungs. And they stayed in iron lungs. They had domes around the head of the iron lungs. Now, one time, so when they opened the iron lung for the nurse to work on the body, they ventilated the patient by giving air into the dome. I actually asked Mr. Jack Emerson why they put domes on iron lungs. Why didn't they just put a mouthpiece in the patient's mouth? Mr. Emerson told me they never thought of it. Okay. Then in 1952, there was a big polio epidemic in Denmark, in Copenhagen, but they didn't have any iron lungs. Now, there was a doctor there who had learned intermittent positive pressure breathing from a Dr. Cournand in New York City in 1947, 1948. Now, he put two and two together, and he realized that if you give positive pressure, breathing, inspiratory positive pressure, why couldn't you give it through a tracheostomy tube? They were putting tracheostomy tubes in people since the 1860s, but they never used trach tubes to ventilate anybody. They used iron lungs and body ventilators. All right, so they put the trach tubes in people, and they had 400 medical and dental students bagging the patients, hundreds of patients with polio, 24 hours a day, 70 at a time, 24 hours a day, were being bagged to ventilate them by medical and dental students in Copenhagen for 4 months until the Danes created a positive pressure ventilator called the Pulmonary. Now, the Pulmonary was rolled behind the patient. The patient was taken out of the iron lung. And so the doctors were thinking, "My, this is great. You put a trach tube in, and you can get the patient out of the iron lung and roll the ventilator behind the wheelchair, and you can mobilize your patient." Now, American surgeons heard this and thought, "Ooh, this is great. We can put trach tubes in people and get them out of iron lungs." So they did that. They said to everybody, "You need a trach tube to get out of the iron lung." Well, Dr. Affelt at Ranchos Los Amigos in Los Angeles said, "Some of our therapists struggling with iron lung patients noticed they could simply take the positive pressure attachment, apply a mouthpiece, and hang it by the patient's mouth. We even had a patient with no breathing ability who has fallen asleep and been adequately ventilated by this procedure, so that it appears to work very well. And I think it does away with a lot of complications of tracheotomies. You just hang it by the patients and they grip it with their lips when they want it. And when they don't want it, they let it go. It's just too simple." That was 1953. I wrote the first paper on a population using mouthpiece ventilation in 1993. Respironics put a mouthpiece ventilation mode on their Trilogy ventilator in 2013. That was 60 years later. After my article in 1993, the centers in our website, breathenvs.com, have been using mouthpiece ventilation and non-invasive ventilatory support, but nobody else has. But after 2013, when it became a ventilation mode on a popular ventilator, many, many more people are trying mouthpiece ventilation and non-invasive ventilatory support. So it took 60 years for this to get into any kind of practice at all. The Trilogy also has a KISS trigger where there's no backup rate. It delivers the air when you touch it, which can be nice, instead of having air being blown in your face. Now, people for daytime ventilatory support can also use a pneumobelt. A pneumo belt is a girdle with this air sac in it. The air sac is in the girdle worn under the clothing, and the ventilator behind the wheelchair delivers air to the air sac. It's made in Italy, the Luna company, the DIMA company, DIMA, and it ventilates patients very nicely unless they have severe scoliosis. But it even helps people with scoliosis, the pneumo belt. When people get weaker and need some daytime ventilation, you know, there's a lot of SMA patients. Generally, the vital capacity is much higher in SMA when you're lying down than when you're sitting. So there are people who can breathe okay when they're lying down, but when they sit, their diaphragm sags and they can't breathe. An abdominal binder can be helpful, but a pneumo belt is like a super abdominal binder. It'll definitely ventilate you without having anything in your nose, your mouth, or your neck. So how do you avoid the respiratory failure and tracheotomies? Well, this is an oximetry protocol. It's an oximetry CNVS MIE protocol. Non-invasive ventilatory support and the mechanical insufflation exsufflation are used to maintain the oxygen saturation 95% or more. That is the protocol. This is not rocket science, but it works. If your saturation never goes below 95, you should stay away from doctors and hospitals for respiratory problems. You don't have respiratory problems. You can get an antibiotic and stay home, you're better off. Now, of course, if you have a high fever and you have hypoxia, it's a different matter. But if the saturation is normal, 95 or more, I recommend you stay home, use your cough assist, keep your saturation normal, and you'll get better. But this only counts when you're awake, because when we're asleep, we all go below 95. So I really tell parents not to worry so much about the oxygen saturation when patients are sleeping. But that's another story. You have to really read about that one too. Okay, so that's what we do. What else do I want to tell you about this? Oh yes, nobody gets oxygen. Giving oxygen is like putting a Band-Aid on a cancer. The cancer is hypoventilation and airway secretions. If you have hypoventilation and airway secretions, your saturation will go less than 95. If you don't get it back up to 95 or more, you will end up with pneumonia. Giving oxygen does not solve the problem. It only makes it worse, much worse. The ventilatory drive controls the ventilation if it's not depressed by oxygen and sedatives. Sedative medications are also not good. Turns off your drive to breathe. Okay, extubation and decannulation. Now, normally patients have to be able to wean from the ventilator to be extubated. That is to have the tube taken out of the nose or mouth and have come off of the ventilator. You have to be able to be strong enough to breathe and have little secretions and a good cough. That's what the extubation parameters state. However, none of my patients satisfy those. Virtually none, very few. But we extubate them anyway. This is a patient with SMA type 2. She has a long face and cannot use mouthpiece or nasal ventilation because all the air leaks out of her mouth. When she was 10 years old, she was intubated at a hospital in New Jersey. She failed 2 extubation attempts, was transferred to us, and we extubated her. And when she was 27, that happened again. When we extubated her, it was even difficult to do to a mask covering the nose and mouth. So we got this new mask. It's called a new mask. Now, what it does is it ventilates through the mouth, but the foam seals the nose so that the air doesn't leak. And without this, it would have been much more difficult to extubate her. She failed 2 extubation attempts at the age of 27 also before getting transferred to us. That was the new mask. Oh, I don't have a photo of her 2 weeks later, but she's fine. She teaches in school and she's fine. Now, this is using the cough assist on a patient who is in critical care, who we extubate. Oh, there she is. That's the young lady who I showed you before. A little bit out.
I think we're still stuck on the Respironics picture.
What's that, Andy?
We're still stuck on the ventilator picture. I don't know whether.
No. There's no ventilator here. This is we extubated the patient to non-invasive ventilatory support using.
No, I mean the slide hasn't changed.
Yeah, it has. Oh, what slide are you looking at?
I'm I'm looking at the Respironics a couple of slides back.
Really?
Yeah, do you want to stop sharing and share again, see if we can get it?
Well, I'd like to know what image you're looking at. Did you see the pneumo belts?
Don't.
The belt on the belly, the belt on the belly.
No.
You did see that?
We're on slide 80.
80, that was the trilogy. Yeah, that was the trilogy. Okay, okay. So I'll say stop share.
Yeah, stop share and share again.
All right, and then I'll say share. Share. All right, let's see.
Fingers crossed. Refresh.
All right, let's see. Share. Can you see that ventilator again?
Second, it's just thinking about it.
It says you are sharing the screen. This is Zoom? That's what this is?
Yeah.
Yeah.
No, it's not showing.
You don't see it. Well, let me see. Yeah, you didn't see the pneumo belt. That's kind of important.
Hold on, let me just, I'm going to share my screen for a second like we did last time. Now I'm going to stop sharing, and then if you start sharing again, hopefully that worked last time. Do you want to try sharing again, John?
Okay, I clicked on share. Look, let me click on X first. And now it says share screen. You know, there's several things here. Let me go back even further. I shouldn't say leave meeting, should I? No.
No, don't do that.
No, okay. All right. I see your photo.
Yeah, so I've stopped mine now. So
okay, this says launching Zoom. I'm clicking Zoom exec, so maybe I did come out. I don't know.
have you got your share screen button back?
No. It's
Hover around the top or the bottom of the screen.
not yet. No. Search your PC, the cloud, and the web. It says right now. I can take some questions right now.
Yeah, sure. I'm basically, if you just need to try and find your share screen button really. But we've got loads and loads of questions.
Yeah, well, let's do some questions.
Okay. Right, we have got first question. If you're an adult who has a BiPAP, how would you suggest the management of transitioning onto these kinds of pressures, as we may not have full lung capacity?
No. What are the settings you're using? See, if you're using BiPAP, it should always be at least about 22 and 4, at least. And the older you are, the higher the inspiratory pressure needs to be because the lungs get stiff, especially if you've been using BiPAP at very low spans for a long time. See, BiPAP is cheaper than a ventilator, and you can use it. You get used to it, and that's fine. But you're not resting your muscles if you're using it at a span less than 15 to 20. Okay? So the first question is, what settings are you actually using? Now, most people in the United States are put on 10 and 5, 10 and 4, which is virtually useless. Okay? So anyone asking that question needs to look at the settings that they're already using. It's possible that somebody was smart enough to put you on good settings, but in the United States, that would be almost impossible.
Okay. Well, that person may respond with their settings. So
yeah, but in general, it needs to be about 22 and 4. In other words, the EPAP should be the absolute minimum, which is 4. And the IPAP should be high enough to give you a full breath, which is usually 18 over the 4.
Okay. Next question. How do we explain to doctors who are convinced that CPAP is the way with SMA children?
CPAP? CPAP is completely worthless because it doesn't give you a deeper breath. Look. Get some of my articles. For example, I wrote an article about pectus excavatum in SMA type 1. So if you give CPAP or nothing at all, the chest does not expand and the lungs do not grow and the patients end up dying. They get respiratory failure and they get intubated and they either get trached or they die. CPAP does not give anybody a deeper breath. So that article says that everybody with SMA type 1 with paradoxical breathing, and that's half the patients with SMA type 2 also, needs to be on NVS, non-invasive ventilatory support settings. So that's number one. Number two, any doctor who doesn't realize that CPAP does not give you a deeper breath is kind of strange because, look, lay people understand this easier than doctors. Don't ask me why. I went to an engineering school. In engineering school, you actually see genius. In medical school, you don't see any genius. You see people with good memories who touch all the bases and all that kind of thing. But I never saw any genius in medical school like I did in engineering school. With that being said, if you're too weak to breathe, you don't need anything stopping you from exhaling. You need something to help you inhale. So in other words, the first half of the CPAP is what you need, okay? Let's say that you're on CPAP of 10. If you could turn off the EPAP and just use the inspiratory, if you could get to 10 just when you inhale, you get a deeper breath. That's what people with weak muscles need. Now, any doctor who doesn't understand that, I think you're better off getting another doctor. At least with BiPAP, the doctors have slight understanding that the difference between the IPAP and the EPAP gives you a slightly deeper breath. But with CPAP, it doesn't give anybody a deeper breath. It's only good for obstructive apneas. And then you have to use your own muscles to breathe. And when your muscles are weak, it doesn't do you any good. So try to get a different doctor or, you know, I'm happy to explain this to anybody, but I've written 9 books and 280 articles in medical journals and pulmonary journals. Now, there's so much medical literature, I don't blame doctors for not reading my books and articles. And also SMA is a relatively rare condition, so they don't want to spend the time to learn about something for one particular patient. They just don't have that much time, especially in the COVID-19 era. So, I mean, I understand that. So you're better off sometimes going to a general doctor who acknowledges that he doesn't understand the disease and is willing to take advice from people like me who have been taking care of SMA for 43 years.
And can people see your articles on your website, John?
Not all of them.
Okay, but if someone wanted an article on a particular subject,
you send me an email, I'll send it to you.
Perfect.
Email and I'll send it to you. You know, the website breathemvs.com. All the centers in the world that use non-invasive support are that I know about are on that website. Now, are there any in England? No. There is one respiratory therapist who I highly recommend. Her name is Michelle Chatwin. I think she's at the Brompton in London. She understands most of this. But the doctors are not on the website. So, but they understand a lot about non-invasive ventilatory support. I know that they do. Okay. Michelle, there's not a single pulmonologist. I mean, Nick Hart in London also does understand some of this, but he doesn't take care of people with weak muscles. He takes care of lung disease patients, you know? That's the problem. Michelle takes care of people with weak muscles and SMA.
So just mention that name again at the Brompton.
Chatwin, C-H-A-T-W-I-N.
Okay, brilliant. And just go mention your website again so people know where it is.
Yeah, it's unfortunate you can't see the images, but it's breathe, B-R-E-A-T-H-E, NVS.com. By the way, many, many, many years ago, there was an article in the London Times that the British don't speak good English.
I remember once being in America and having to order McDonald's 3 times because they wanted to hear my accent. Right, next, this is more of a statement, so I'd be interested in your opinion. Someone's posted, unfortunately, I've seen too many patients die of plugs while on BiPAP, whereas it much, sorry, it's just moved. It's just moved. Oh, it's typical, it's been there for ages and it's just moved. Basically saying that being on the track is easier to manage and is less risky for plugs.
Well, as a matter of fact, you can die from mucus plugs with trach tubes also. But I'll tell you right now, that none of those patients who died from mucus plugs had cough assists or knew how to use them. And I will say something else. It is true that your chances of survival until age 3 are greater with a trach than without one. But after age 3, they go down. So after age 5, none of my SMA1 patients died because they don't have any airway secretions, because they don't have trach tubes, they're positioned well, and they never get hospitalized.
Okay, so I've got the message now. So
Okay.
it's much easier to remove a plug if tracked. Our daughter is much easier to care for now. She's been tracked, and much easier to find nurses who are willing to care for her.
Yeah, no, that's true. The nurses understand how to suction trach tubes. But I suspect she was trached before she was 3 years old, right? Well, you can't ask that question, I guess. See, first of all, the trach tube causes the mucus and the plugs. The average trached patient is suctioned 7.7 times a day because of secretions created by the tube. Now, when you're under 3 years of age, it is true that it's easier in a sense to clear those secretions through the trach, but understand something, 95% of the time, when you put a suction catheter in a trach tube, you do not get the left main stem bronchus. You do not clear the left lungs. This is why over 80% of pneumonias are in the left lung. When you use the cough assist correctly, it creates a flow of air that clears both left and right lungs. And this is why, but even with that being said, the average SMA1 patient without a trach is intubated 0.7 times a year till the 3rd birthday, then 0.3 until the 5th birthday, and then less than 1 in 15 years after age 5. I have now 9 or 10 that are over 20 years of age with SMA type 1, 24-hour vent dependent since they were infants. There are not that many trached patients over age 20 in the whole country, in the United States, that are clearly SMA type 1, that are trached and over 20 years of age. So the chances of survival till age 3 are greater with a trach tube. They are less after age 5. Same thing is true with muscular dystrophy. With the trach tubes, the average survival is to age 29. And most patients die because of complications of the trach. Without a trach tube, the average survival is to 40 with Duchenne muscular dystrophy. It's the same kind of thing. So it does seem to be easier to clear mucus plugs through a trach tube when you're under 3 years of age. But after that, the mucus is caused by the trach. And also, I guarantee you that those mucus plugs killing BiPAP babies is because nobody taught them how to use a cough assist or a mechanical insufflator or exsufflator correctly. I guarantee it. It's
okay.
Never used at proper settings.
Okay, cool. That person we were talking about with BiPAP, they've come back and their settings are 16 and 5.
Okay, so that's a pressure, a support of 11. 16 and 5 is 11, yeah. That's actually not bad, but it's low. It should be gradually go up to 20 or 22 and immediately put the 5 down to 4. I mean, that's what I would recommend because that will give better rest for your muscles during sleep and it will improve your blood gases better during the day and you should feel better during the day. You should feel a little bit better. But a pressure support of 11 is a lot better than you would have gotten in the United States.
Okay, excellent. Can you please run us through normal and sick settings, RR rates, inspiratory rates?
I didn't understand the question. What did you say?
The question is, I guess they're asking what settings should they use for patients or children that are either sick or well or...
Well, you see, the settings should always be the same. Full, non-invasive ventilatory support. Basically 18 and 0. Ideally, the settings for small children with SMA 1 and 2 should be 18 and 0. 18 to 20 and 0, maybe 17, you know. But it should be 0. If you can't turn off the EPAP, you got to increase the IPAP by 4. So then about 21 or 22 and 4. But you see, those settings, you can increase them a little when somebody is sick, but you normally don't have to because they're full ventilatory support settings. But some people, when they get sick, they like to increase them for deeper breaths.
Okay. What about kids who are BiPAP dependent? When would you say they are better off being tracked?
Never, never. They won't survive into 25 years of age like my patients if they get trached. And they see, they really should not be using BiPAP. I mean, if they're using BiPAP 24 hours a day, in the United States, BiPAP is not considered a ventilator. Now, it can be used like a ventilator, but it isn't because the doctors don't seem to know enough to use it as a ventilator. How is it used as a ventilator? By using it at 22 and 4. But it's never ideal because of the EPAP. So if you cannot get a ventilator and shut off the EPAP, then if you're using 22 and 4, he can use that until he's 50 years old. The problem is when he gets sick. When the patients get sick, if they get pneumonia and need to be intubated, all the doctors think they can't extubate them back to 22 and 4, but they can. But they have to use the cough assist every 20 minutes after the extubation, and they won't do that, which is why I always have the family do it. See, understand what I'm saying. When someone gets intubated for respiratory failure, they have to pass ventilator weaning parameters, or the doctors won't extubate them, and they'll tell you that the patient needs a trach tube. I don't bother with weaning parameters because many of my patients can't wean anyway. But I use the cough assist through the translaryngeal tube, the intubation tube, every hour to clear the secretions out of the lungs completely. And in 1 to 3 days, the oxygen saturation becomes normal in room air without giving oxygen. At that point, I extubate the patient to non-invasive ventilatory support settings, which is like 18 and 0. But I always have the family there after the extubation for at least the first 36 hours to use the cough assist through the upper airway to clear the mucus. Otherwise, the mucus can build up, the extubation fail, and the doctor says, see, I told you he needs a trach tube. See, I didn't get to that because the extubation and decannulation, I was just starting to talk about that when you told me that you weren't seeing any of the images. So I didn't get to talk about that. But that's basically what we do. You can be a 24-hour vent user stably forever. But then if you get a bronchitis or a flu or something, you may need to be intubated. If you get intubated, there's no reason you can't be extubated back to what you were doing all these years. But the doctors don't understand that because they think that you have to be weaned to be extubated. We extubate patients back to full non-invasive ventilatory support, patients that are not weaned at all. And we don't have a 99% success rate. It just doesn't fail. So that's why, for example, I showed you some patients who were 25 years old with SMA type 1. There were 2 brothers. Amazingly, those brothers became 24-hour dependent on nasal ventilatory support at 4 months of age without ever going to a hospital. The first time that they got intubated, they were 8 and 12 years old. Each one had pneumonia. We intubated them for a week, and after that, we extubated them back to what they had been using for 8 and 12 years. And now they're 25 and 23 years old. The second boy that I showed you, whose parents I said would need a trach or would die within 1 year, who's 26 years old now, he was intubated 10 times by the age of 4.5 because he had brothers and sisters who were bringing cold germs home from school. 7 times he failed extubation attempts in New York City hospitals, got transferred to me. I extubated him back to non-invasive ventilatory support, and now he hasn't been hospitalized in over 10 years. And he's 26 years old, okay? Now, there's no reason for these patients to die because if they get pneumonia, I know we can always extubate them back and not have to trach them. If they get trached, they will probably eventually die from complications of the tube because the tube, there are 2 chapters in my book about the horrors that occur over time with tracheostomy tubes. I can talk about it for hours. But anyway, I told you it's going to have a total money-back guarantee when I get that book done.
Okay, great. Just a nice comment from Sarah saying that yeah, her daughter is still alive because of all the research and the advice that you provide. So people are really, really keen on what you do, John. Got another question. Weak type 1s that have no swallow have hard time handling secretions. Trachea makes that management much easier. Would you have any comments on that?
Yeah, sure. Yeah, it would seem that way. But then I have to ask you, how come my 10 patients who are like over 20 years old, they have normal oxygen saturation in room air and don't have any problem with secretions? The answer is because of positioning. And that is the entire answer. They cannot protect their airways with the glottises because their glottises don't close. That's why 25 years ago, I actually told the parents of 2 different boys that they would be dead within 1 year without a trach tube. And now that 25 years have passed and I was totally wrong. But when I look at what the parents have done, the boys sit forward in the wheelchair, so they drool, they do not aspirate. And we all aspirate to some degree, but if the oxygen saturation baseline stays normal in room air, we're not aspirating too much. But the whole thing is positioning. You cannot lie on your back with your face forward and not aspirate if you're SMA type 1. You have to be side lying, you have to be lying, and you have to be sitting forward when you start sitting. But, you know, these parents have figured this out. But the entire thing is truly positioning. I swear, like any other doctor 25 years ago, I really believed that because they have no bulbar muscle function like my ALS patients, they would need trach tubes like my ALS patients. And none of my patients have gotten trached in the last over 20 years. And very few of them have died. In fact, virtually none have died locally. Now, I had an image about SMA ones around the country. There were 41 on non-invasive support elsewhere. 28 have survived more than 10 years, and 13 died. But we don't have that kind of death rate. And I think the reason is because we very well train our families how to use the cough assist to clear mucus plugs. And most of my patients have a home care company where all the respiratory therapists are on call 7 days a week, 24 hours a day, and every single therapist is an expert at how to use the cough assist and non-invasive ventilatory support. When my patients have other home care companies, it can be a nightmare because the therapists and the nurses have no understanding of any of this. So they have to be taught by the parents. And if the parents aren't properly taught by us, the patients don't do so well. So I can certainly understand, there's a center in Rome, Italy that published a paper that up till age 3, the survival is a better chance with the trach tube than without it. And I myself have published that hospitalization rates are greater until age 3 without a trach tube than with it. I understand that. But I think your chances of your child surviving 30 years are very, very small, if 0, or close to 0 with a tracheostomy tube. They're not 0. I had a 22-year-old who died from respiratory complications with a trach tube since he was 2 months old. And I know that there are others over 20 years of age with trach tubes. So occasionally people do survive. But I'm sure that your chances of surviving after age 5 are much greater without a trach tube than with it, because you completely prevent aspiration.
Okay, excellent. Question about cough assist. Over 40-40 is suggested. Also, do you suggest doing exhale function only for lung expansion?
No. You see, there's 2 reasons for using a cough assist. Now, you know, you got a British company. The girls that work there are very nice, nippy. They make ventilator. I forget the name of it though. I think she'll be upset with me, but they have a cough assist also, a sort of a cough assist. So if I say cough assist, I'm talking generically. The thing about the Respironics cough assist though is to be able to measure the expiratory flows. The other thing that's very good about it is that babies can trigger it. See, one of the problems with trying to use a cough assist on a child under the age of 3 is that they don't cooperate with it. But if you set it so that the child triggers, his breath triggers the machine, it works better. See, these are things that have to be taught to the parents. And if you have a sort of a cough assist that doesn't have that function, then of course you got a better chance to survive with the trach tube than without it. You understand what I'm saying? See, my patients around here get optimal management because all the therapists taking advantage of them are experts in doing this, and we make their parents expert. But the SMA ones from other parts of the United States who don't have these expert therapists, well, most of them do survive 10 years or more, but not 99% like around here, you see. So it is possible to achieve this, but it requires a commitment by, well, in our case, the home care respiratory therapists, as well as the doctors. I mean, now, somebody like Michelle Chatwin, who I've mentioned several times, she's a respiratory therapist and she understands a lot about non-invasive support and cough assist and all of that. She has a tendency to use the cough assist at too low pressures, in my opinion. Don't quote me on that, she'll get upset with me. But this is the point. I do not think she has any access to patients in critical care, which means that you can manage a patient on 24-hour BiPAP or non-invasive ventilatory support. But then if they get a bronchitis and get intubated, you lose control of them. And then you've got 7 intensive care doctors saying, no, you're too weak to breathe. We have to trach you. We can't extubate you. You see the problem? So I don't have that problem because my patients locally, when they get intubated, I extubate them. There's no way anybody's going to suggest a trach for them. And I'll tell you something that's kind of a funny story. I showed you an SMA 1 who's 26 years old, who had, the last one I showed you was a girl, and her teeth were, not in good shape. And I didn't really talk about her much. But the last time she was intubated, she was 12 years old. Now she's 26. When she was intubated at the age of 12, the respiratory therapist and I said to her mother, you extubate her. We actually stood at the foot of the bed, and the mother extubated her and put her on her nasal ventilation, used the cough assist as though we were not even there. So this is not rocket science. If the mother of a child with SMA1 is so proficient at using non-invasive ventilation and the cough assist for her child that she can actually extubate her in the critical care unit, why can't the critical care doctors? I'm laughing thinking about it myself, but what I'm telling you is a true story. I'll tell you another thing that happened to me that shocked me. That didn't shock me because we told her to extubate her daughter. I was in the home of an SMA mother with a baby with SMA type 1. And I rang the bell, come through the door. She's on the telephone with her girlfriend. And she said to her girlfriend, all right, 6 o'clock tonight, you come over and, in the meantime, her baby had a mucus plug and stopped breathing. Well, she put the phone at her ear. With her 2 hands, she took an ambu bag, blew air into his belly, into his lungs, pressed on the belly, blew out the mucus plug, and the child was fine, normal saturation. And I said to her, how often does this happen? And she said, oh, it happens from time to time, So the mothers become better than respiratory therapists of these kids. And if the parents don't want to learn how to do this, then the kids are better off with trach tubes.
Yeah.
If they want to learn how to do it, the doctors need to be willing to teach them how to do it. And a lot of doctors are not willing to get the patients' families involved in their care in the United States.
Okay, fair enough. Right, another question. I found over the years that my son's diet is so tied to his respiratory health. For example, giving him the wrong oil in his diet, he has major reflux and life-threatening plugs. Can't seem to find SMA care team that recognizes an SMA patient's diet and respiratory health. Have you been able to make any headway with studies around that?
Wow. Yeah, well, as a matter of fact, I didn't mention this because I want to finish this book of mine, right? And the book is actually, though, in 2 volumes. The first volume is not cardiorespiratory, and it is printed. I'm not really selling it. I mean, if anybody wants it and they send me $20 plus shipping, I'll send you the book. But the reason I'm mentioning this, it's going to eventually be on the website. I don't even think it's on the website at this point. Is that there's a big chapter on nutrition, and a lot of it is about SMA. Now, you guys are in UK. In the United States in 1999, Dr. John Kelly wrote some interesting articles on nutrition and SMA about the fact that kids with SMA have a metabolic problem in metabolizing free fatty acids. And that there are certain oils that are recommended, and we use Vivanex, pediatric Vivanex, and other medications and a special diet. Now, there's a woman in Florida by the name of Mary Batzel, who has been on everybody's back about this type of diet. In fact, even in my 2004 book, I have a big section on this material. That book, though, is kind of selling expensively, like $60, $70, $80, $90. If you really want to learn about this subject, then send me an email. I mean, I'd sell you my book for only 20 bucks, but to ship it to England would probably cost at least 10, probably even more. So that's the only problem. But there's an 80-page chapter on nutrition, and a lot of it deals with SMA. And a lot of it deals with oils and managing fatty acids and SMA. It's written by a Dr. Patricia Kane, who is a big lipid maven in the United States. She puts on courses every year on all of this, lipids and nutrition and SMA and all of that. So her name is Dr. Patricia Kane. She actually lives in New Jersey, K-A-N-E. She did the chapter on this in the first volume of the book that I'm trying to finish now. But like I said, if you send me an email and you want to send me $20 plus shipping, I'll send you the book. You will find it interesting, I'll tell you that. I don't mention it because for me, cardiopulmonary management and quality of life are the most important aspects of all this. But the first book has equipment, gastrointestinal management, nutrition, and many other things like that.
Okay, thank you. Loads of questions coming in, John, so you'll need to tell me when you've run out of time.
Yeah, I'm gonna have to shut this window because the kids next door are making a racket.
So I've got another question. What pressure do you recommend for cophocysts?
Yes.
European guidelines are now a span of 5 between the numbers, for example, 35, 40. These are the guidelines that Michelle Chatwin follow.
Yeah, but that's why I said before, I love Michelle. She's a wonderful therapist and human being, but the people who make the cophocyst, Philips, Respironics, and I, do not agree with the way she uses the pressures, because let me tell you why. First of all, the coughlator was on the market from 1953 to 1967. It was calibrated in millimeters of mercury, and it was always used at 40 millimeters of mercury, always. And it was studied extensively at 40 millimeters of mercury, in and out. There are physiology studies, there's clinical studies, all of it done at 40 millimeters of mercury, in and out. Now, in 1988, I convinced Mr. Emerson to make the inexaflator, the cophocyst. He got it on through the FDA in February of 1993. I think it appeared in England around 96, maybe later. But I helped him get it through the FDA by saying that they were equivalent. It was equivalent to the coughlator. But I missed the fact that the new machine was calibrated in centimeters of water. 40 millimeters of mercury is 54.1 centimeters of water. Nobody used the cophocyst at less than that through 1967. And the patients who had coughlators continued to use it that way until the new machines were made in 1993. So understand what I'm saying. All the studies done on it and how effective it was were on 54.1 centimeters of water. Now, in 1993, when it came on the market, I wrote these 3 review articles where I said that the 2 machines were equivalent, but I didn't point out that the difference was how the flows were calibrated. So everybody started using it at 40, but not 40 millimeters of mercury, but 40 centimeters of water. Or to be cautious, they were using it at less than 40. Now, I have done a study with Dr. Goncalves in Portugal, who has been dragging his feet in getting this thing published. He's been driving me crazy. But we have data on hundreds of patients, and in nobody should it ever be used at less than 40 centimeters of water pressure. Now, it is true that some people will close their upper airways, and you have to deliver it slowly and go down on the pressures for some patients, but only for patients with upper motor neuron disease. This is why ALS patients need trach tubes, because when they use the cough assist at adequate pressures, sometimes it doesn't work because their upper airway closes. This does not happen in SMA, period. How do I know that? All right, I'll tell you. When I use the cough assist on babies with SMA type 1, I use 50 centimeters of water pressure, and my flows, I get 50 to 70 centimeters of water, 50 to 70 liters per minute of flow, okay, 50 to 70. On my 5-year-olds, I get 150. On my 25-year-olds, I get 370 liters a minute of flow. This is more flow than I would get if I did it. In other words, as the SMAs get older, their airways get bigger and their cough assist flows go up and become extremely powerful. And this is why these patients never get hospitalized anymore. After the age of 5, the cough assist flows are very effective and they almost never get pneumonia anymore because they know how to use the cough assist. This is one of the biggest problems, that people are using the cough assist at inadequate pressures and at inadequate frequencies. I'll give you an example of a ridiculous thing. I had 4 patients transferred to me from Qatar. 3 of them were intubated, couldn't be extubated, so I extubated them and sent them back to Qatar. One patient, we extubated the patient, but the patient needed scoliosis surgery. So she went to Columbia Presbyterian in New York City for the scoliosis surgery. When she got there, they changed my prescription for the cough assist. They made it 40 centimeters of water, 10 seconds in and 10 seconds out, which meant that if she could use it, she would get 3 breaths a minute. And of course, nobody could survive with 3 breaths a minute. You know, 10 seconds in, that's 20 seconds. That's 3 breaths in 60 seconds. Yeah. She didn't even get through the 10 seconds in. Why physicians do not understand that people have to breathe. You know, you need 6 liters of air a minute ventilation. I don't understand. I don't know. But some people understand.
So in terms of the settings, is 40.
Nobody should use 40. Okay. Even on babies, we use 50 to 60.
Okay.
But we have to get the babies to trigger it themselves, because if the baby doesn't cooperate with the machine, it doesn't do the baby any good if he's breathing against it. How do you get him to cooperate with the machine? I'll tell you how. When the belly goes out, the baby is inhaling. When the belly goes in, the baby is exhaling. You time the insufflation with the belly going out and the exsufflation with the belly going in. Okay? That's how you get the baby to use the machine. Now, it's easier if the baby will trigger it, and on the cough assist, you could set something called the cough track and let the baby trigger at 50. But the baby won't be totally in sync with the machine, at least until they're 3 years old or 5 years old and so on, which is why it is difficult to get them to age 3. But after that, they do far better without a trach than with a trach. But again, you got to know how to use the cough assist properly, and someone's got to teach you. And I'm not sure anybody in England really knows how to use the cough assist properly. I mean, you know, Michelle has been using the cough assist for a long time, but the article I read where she's trying, you know, pressures less than 40. See, the reason that she did this is because she used the British machine, and the British machine does not have the ability to measure the cough assist expiratory flows. What she said was, well, we could hear the patient had a more powerful cough, blah, blah, blah. But that's not precise. When you use the so-called cough assist from Respironics, you get the actual expiratory flow created by the machine. And if that flow is over 200, nobody needs a trach tube, because you can clear the secretions very effectively with the cough assist. If that flow is under 100, everybody needs a trach tube, because that means you've got stridor and your upper airway is collapsing. But you've got to see those flows, and she did not see those flows with the machine that she used. So so I think she came to the wrong conclusion. But I haven't seen anybody benefit at pressures less than 40, and we don't use pressures of 40 on anybody except for upper motor neuron disease patients. We use 50 to 60. And when you use it through a trach tube or a translaryngeal tube, an intubation tube, you've got to use 60 to 70 because the tubes are very narrow and there's a big pressure drop off. Another thing that's very important to understand, a lot of patients are told to set times, 2 seconds in, 2 seconds out. That's nonsense. What you want to do is manually see how long it takes for the chest to fully expand. And when the chest is fully expanded, then you go to empty it, okay? That might be 2.7 seconds, might be 1.7 seconds, but you don't know until you measure it. Now, 2 seconds is a good estimate, all right, but we don't let anybody set times on a cough assist until we know how long it takes to fully expand the chest and fully empty the chest, you see. So, that's my message. And the higher the pressure, the faster you can fill the chest. The pressure on the cough assist is not the pressure in the lungs. And the reason for that is because the lungs have hysteresis. Hysteresis is an inertial factor that you have to apply 40 centimeters of water pressure for more than 10 seconds to the lungs before it will really fill, over 90%. So the pressure on the machine is not something to be afraid of. It's looking at the patient. We don't treat patients anymore. We treat numbers. You got to look at your patient and see how long it takes for the positive pressure to fully expand the chest till the chest stops expanding, and then go to the negative pressure. It's much better to use the manual cough assist mode than use a timing, in my opinion, because you're looking at your patient and you're actually treating the patient instead of setting numbers on a digital device, like I spend too much time doing anyway.
Okay, another question. I have no idea what this means, but
okay.
Many patients in America follow Schroth protocol. Do you?
No, that's Schroth. Yeah, Mary Schroth. Yeah.
Okay.
Yeah, I know her. Yeah.
And do you agree with that protocol?
Well, as far as I know, it's the same as ours, but some of her patients end up getting trached and none of ours do. See, Mary used to be a clinician, but now she's an administrator. She's the medical director for TreatSMA. So she doesn't really treat the patients anymore. Now, she learned non-invasive ventilation from me. She'd be happy to tell you that, I'm sure. But she never got to extubate patients when they got into trouble because she never worked in critical care. So as I understand the Schroth protocol, she's using non-invasive ventilatory support up to 24 hours a day. Did she change her mind and say that if you're using it 24 hours a day, you should get a trach? See, I really don't know. I haven't seen that recently. But she learned non-invasive ventilation from me. She did a wonderful job, but she's not a clinician anymore. She's a medical director for TreatSMA, and she never worked in critical care. So she doesn't have patients. So I'm sorry, I don't know exactly what the Schroth protocol says right now. I should really look it up to see what she's telling people, because she talks about, she sends patients who don't want trachs to me. So she sent me a couple last year. But that's because she's not treating them anymore. That's because she herself is not treating them.
Fair enough.
Before that, she was doing a great job. She had people on 24-hour non-invasive ventilation. I know that.
Okay, I've got another question, and this looks like it's coming from a clinician. Do you use IPPB as LVR techniques?
Well, LVR is lung volume recruitment, and there's active and passive. Now, active is air stacking, where you get a volume of air, you hold it, get another volume, and you fill your lungs with air. SMA1s cannot do that. SMA2s definitely can, and 3s and 4s and so on. If you cannot air stack, then you can do passive lung volume recruitment. Now, the cheapest way to do that is to get an adult ambu bag, a manual resuscitator, block the exhalation valve, and pump up your patient until you get resistance and can't put any more air in the lungs. We call that the lung insufflation capacity, as opposed to the maximum insufflation capacity, which is done by air stacking. So lung volume recruitment is extremely important. Now, the person mentioned IPPB. That normally means intermittent positive pressure breathing. IPPB used to be a technique in the 1940s, which was used to deliver medications to asthmatics under pressure. You'd set the pressure to 15 centimeters of water. It would give you a deeper breath with the medications. However, IPPV, which is intermittent positive pressure ventilation, normally implies that you're setting a volume instead of a pressure. It doesn't have to mean that. So like I told you a long time ago, you can deliver a volume of air that creates a back pressure of 18, or deliver a pressure of air that creates a volume of 600 milliliters, okay? Delivering a volume or a pressure makes a little bit of difference, but depends on what your goal is. If it's for lung volume recruitment, it doesn't make any difference. If you use the cough assist at 70 centimeters of water to really fill your lungs with air, that's the same as air stacking 1 liter of air after another until you fill your lungs with air to a pressure of 70 centimeters of water. I have people who've been doing this for over 60 years. Nobody's ever had any damage to their lungs. They've actually kept their lungs healthier by doing this. So when that clinician mentioned IPPB, the technical definition of IPPB was setting a pressure of about 15 to 18 centimeters of water, which is not nearly enough to do lung volume recruitment, because to really fill your lungs with air, you need to go to pressures of 60 to 70 centimeters of water. So that's for sure. You got to start at 50, or you're not going to be expanding your lungs anyway very much. There was no IPPB machine that went up that high. There was none. Now the cough assist, of course, does. Your ventilators, you can set for a volume and air stack to a pressure of 70, okay? But what I'm telling you is a little bit technical, and I don't know if everybody listening understands everything I said. You can get all this information from the website, breathenvs.com. Everything is explained there. And when I get this next volume of my book done, I really hope you'll buy it. I told you, money back guarantee. You will love this book. I am so critical of people, so-called experts who have no patients managed entirely non-invasively, and you know, they drive me crazy. So
maybe we can get you back to do
yeah. Hopefully in a year the book will be printed.
Right, some more questions. You need to tell me how long you've got, John, because if we don't get through
I can't go anywhere. You see,
okay.
Because, no, my daughters, I have 5 chicks, redheads. I have 5 redheaded chicks.
Oh dear.
I've got 2 new chicks. The 2 chicks arrived on May 7th. They're both redheads, and one of them has delivered 4 eggs now, 1 every day. And these 2 young chicks, I've got 2 17-year-old redheaded chicks, who love them. I mean, they're getting together really well. And then I've got an old chick. Now, I can't say that in front of her, but old chick, all 5 chicks are on a little farmhouse 1 hour north of Montreal. Now, the problem is that the border is closed. I normally go up there every 2 weeks to see my 5 chicks. Well, I used to have 3 chicks, now I have 5. I haven't met my 2 young chicks yet, and I really want to go up there, but the border is closed. So today I'm going to call up United Airlines and say, well, can I fly to Montreal? And if I can fly to Montreal, why can't I drive there, you know? So I don't really understand what's going on now. I know the border is closed, but the airlines are selling tickets for international flights. So I have a feeling this is a little bit hypocritical, that they're trying to stop the airlines from going under by letting people fly internationally.
I know, it's bizarre. And the guidance over here is just as bizarre.
Yeah, it's bizarre. It's bizarre. Now, I can understand if you have thousands of people coming across the New York border. You know, a lot of people in New York State are infected with COVID-19. I understand that. But to allow me to land in Montreal, I mean, what are they going to do differently that they can't do on the border? You know what I mean? So I got to find out, because I haven't seen my 5 chicks or my 3 chicks in over 2 months now.
Fair enough.
So I can't really go anywhere.
Okay, so next question then. This one is, what would you do in an emergency when child goes blue from either, or would you investigate a mucus plug or reflux episode? What should one do?
Well, reflux is like a mucus plug. Reflux is aspiration. You got to use the cough assist at 50 to 60 in and out. The cough assist will not only ventilate your lungs, it will clear your airways. But don't use it at 20 or 30. You got to use it at 50 or 60. It will clear your airways and ventilate your lungs. You could also filter oxygen into the tubing of the cough assist. So I don't like to give any oxygen, of course, not on a routine basis. But if a child is having a mucus plug and arrests, you need to give oxygen.
So I think I'm going to know the answer to the next question. So this person, my son vomited badly from 1 month, and he became dependent on BiPAP, and his X-ray is good and everything is good. How can I improve his breathing? And is it better for him to be tracked? His settings 15/4.
Oh, his settings are 15 and 4. And she didn't say how old he is. How old is he? You don't know?
Doesn't say. You know, it said vomited from 1 month, so I'm assuming quite young.
Hang on. The child vomited once or has been vomiting for a month?
I don't know.
She also didn't say if the child has a gastrostomy tube, because gastrostomy tubes increase reflux and aspiration, and many patients need what's called Nissen fundoplications when they have gastrostomy tubes. You know, this person should probably send me an email and give me better details, because
the child is 18 months.
Yeah, it's a baby. So I assume the baby now has a gastrostomy tube, right?
Selma, are you able to confirm that? No gastro, only NG.
No. Then does the child swallow without aspiration? I mean, because you need to look at a modified barium swallow or a fiber optic view of the swallowing mechanism to see how well the baby is swallowing. I mean, if the baby is not losing weight and gaining weight and swallowing well, and this is just reflux, if it only happened once, then you have to let the baby sleep on a wedge so that the baby is not likely to reflux, to sit more, because at 18 months of age, a baby should not be lying down anyway. The baby should be sitting a lot. Otherwise, if you let a child 18 months old lie down all the time, the intravascular blood volume decreases, and then if he tries to sit, the blood pressure goes down, and they get lightheaded and short of breath. So, you know, you really need more general expert care here. A baby 18 months of age should be sitting most of the time, number one, and have a thoracolumbar brace to prevent scoliosis from progressing too much, okay? So that's number one. Number two, if this was just one vomiting episode, and if it happened while the baby was lying down, then I would put the baby on a slight angle, like on a wedge, so that reflux is decreased. Now, anybody with SMA1, and about half the patients with SMA2, eventually need gastrostomy tubes. If the baby gets a gastrostomy tube, then the baby will also get a Nissen fundoplication, which would prevent aspiration. You see, so this requires a lot more looking into, you know? Now, if a baby vomits like that, you immediately want to suction away the vomitus and suction the airway, and then you can use the cough assist to bring up whatever is deeper. But, you know, vomiting is an emergency because they can aspirate all of that and stop breathing, as you know. So you got to suction and use the cough assist and give oxygen, you know, that's an emergency aspiration.
Okay. Right, next question. Let's have a look. People talking amongst themselves. Why is saturation dropping when baby enters REM? Drops to 92.
That's not dropping. It probably drops more on the person asking the question. Everybody, when we go into REM sleep, into the low 9, it drops on everybody. That's normal. We don't recruit our breathing muscles when we sleep like we do when we're awake. 92, first of all, if the baby is not getting oxygen, it's wonderful. 92 is not dropping, okay? That is normal. It happens on everybody. If it drops below 70, then we have a problem. Now, you can fix that problem by closing the system by using an oral nasal interface or a face shield, but those are other interfaces. I have never had to do that for any of my patients because the patients go back up to 95% on their own if you give them a 30 seconds or 60 seconds. But if it stays below 80 for a long time, like for 5 or 10 minutes, I would be concerned about it, and I would change the interface to a closed interface, like an oral nasal interface or a face shield or something like that. But I've never really seen an SMA1 where the saturation stays below 80 for several minutes. It usually bounces right back up. See, I always tell mothers, don't worry about the saturation when the baby's sleeping in general, because it goes down on everybody when we're sleeping. Now, I got to be careful when I say that, because there are SMA1 kids that have dysautonomia where they have bradycardias and their heart rates can go way, way down below 40. So when the saturation goes way below 80, there can be a bradycardia, the slowing of the heart rate, that is potentially dangerous and should be treated with anticholinergic medications. But anybody going to 92, that is nothing to worry about. That is normal. So.
Okay. Here's another question. What is protocol for an SMA patient if they got infected by COVID-19 and is a weak type 1, 18 months old, BiPAP dependent, and hasn't received any treatment?
Okay, well, I got to tell you, I've had a number of patients get COVID-19, and they have all done remarkably well. And the reason is because consider that 86% of the deaths in the United States are patients with diabetes mellitus, 86%. Now, it's true as we get much older, and I say much older because much older than me, I hope, we will get diabetes. But when we get diabetes type 2, also almost everybody is overweight and they have high blood pressure. So when you consider that 86% of people who die in the United States, and that's over 100,000 people, have diabetes mellitus, what does that tell you? It tells you that we are not dying from the virus. We are dying from our response to the virus. Just like if you get a trach tube with SMA type 2, you're likely to die because of the trach tube, not because of the SMA type 2 directly. The same is true with COVID-19. You're likely to die from your response to the virus. Now, what is that response? That response is inflammation. When you have a lot of fat cells, the fat cells create substances that increase the inflammatory reaction. That will make the inflammation worse and the cytokine storm, as they call it, more deadly. So I think that the reason that 86% of the patients who die in the United States have diabetes, they're dying because they're overweight for the most part, and they have high blood pressure, and they're older. Now, my patients tend to be young. My SMAs and my muscular dystrophies, they tend to be under 40, you know. So that's one thing. Number two, 70% of the patients who are dying are males. So if you have a female baby, I don't really think you have anything to worry about. It's so rare for anybody under the age of 6 to die or have a bad reaction to COVID-19. I don't think that SMA is going to make any difference at all. Now, not only do you have the advantage of being young and maybe being female, but you already have a ventilator. Now, BiPAP is not technically a ventilator, but if you use it at 22 and 4, you're using it like a ventilator to rest your muscles. The problem with COVID-19 and BiPAP is that the BiPAP interface, the mask, has holes in it. And when you deliver air through it, it sprays everybody in the room, okay? So the first thing that should be done if you have COVID-19 and are is you should be switched to a portable ventilator where you could shut off the EPAP and use a non-vented interface, an interface with no holes. But you should also use an interface that covers the nose and the mouth so that the spray doesn't come out and infect everybody in the room. So in other words, you should be changed to doing something that we have been doing all along. I don't put anybody on BiPAP because I can't turn off the EPAP. So I put people on portable ventilators like Trilogies and LTVs with a non-vented nasal interface, one without holes. So there's no aerosol and there's no EPAP. So if somebody on BiPAP with SMA gets COVID-19, hopefully the doctors will understand that you need to be switched to a different system, an oral nasal interface with an active ventilator circuit with an exhalation valve, a closed system, and 18 and 0, basically, okay? So that's a long answer to your question, But
very topical.
you know, but my patients, like I have many patients in Orthodox Jewish families in Brooklyn, and they may have 15 kids, and 1 or 2 of the kids will have a muscular dystrophy. And now what's happened there is the old people in the family have died, and the young ones had no bad reaction at all. The ones with the muscular dystrophy, they were fine, you see. So I really think that people with neuromuscular disease do not have a disadvantage because they already have ventilators and they're young. And presumably they don't have diabetes. Now, diabetes, that's another story.
Okay. Another question, why would somebody need to have their head tipped forward to breathe better?
Well, that depends. On some people, that makes the upper airway open. So for example, on some patients, when we extubate them and they're lying on their backs, the air doesn't get in well. We hear stridor, like that. And we tip the neck forward and the airway opens, you see? So, I mean, it's positional, but it's not on everybody. It's only on a few people, actually.
Okay.
But it's true that by tipping the airway forward, the neck forward, in some people, it opens the airway more.
Okay. Another question. Can you turn the EPAP off on the Trilogy?
Yes, that's why we use it. The Trilogy has 11 ventilator modes. At least 2 of them are BiPAP. I think 3 or 4 are BiPAP. But the other 10, the other 6 or 7 are not BiPAP, which means that you do not have EPAP. You use an active circuit with an exhalation valve, so when you exhale, it goes out that valve. You don't have holes in your nose piece, okay? So you have a sealed interface. It's a closed interface. It's called a non-vented interface or mask. So those are these modes that I use. I do not use BiPAP modes for anybody.
Okay.
Unless they come to me on them and they love them and they're so used to it, but then I increase them to 22 and 4 generally.
Okay, so we've got another one here. I've been using mouthpiece ventilation during the day since 1987, stacking breathes every minute or 2, nasal pillows at night, 1 respiratory infection in 20 years, no hospitalizations for respiratory issues for 20 years, SMA2, age 52.
Wow, that's amazing for England. Because I'm so amazed.
Yeah, gee, thanks.
I was lecturing about this in France and England in 1983. And many of the British neurologists heard me lecture and they just never bothered to offer this to anybody. In fact, I'm not even sure that they do even now. But I guess they do. I shouldn't pick on them anymore. But you were using mouthpiece ventilation in 1982? Did she say 82?
Yeah. 87, I think, 87.
Oh, 87, yeah. See, I went to France, I lived in France from 81 to 83 to teach the French about mouthpiece ventilation. And some British doctors came to listen, but I wasn't aware of anybody offering this in the 80s. But that's wonderful, you know, I mean, that's wonderful. Now, my question would be, do you have access to a cough assist if you get a bad bronchitis? Or a nippy? What is the nippy machine called?
Oh, I don't know, but I'm sure there's someone out there that probably does know.
Yeah, there's because they have a ventilator and they have a cough assist, and I forget what they call the cough assist.
We have our own respiratory expert, Mum, as part of the
Yeah.
team, so I'm hoping Kelly might be able to advise.
Yeah.
While we're waiting for that, we'll move on to the next question. So we mentioned Trilogy a little while ago. Someone is asking, what settings do you recommend on Trilogy?
Well, I said that already. I guess they missed the beginning of my talk.
What mode?
We use volume. First of all, we use volume. And for adults, I set the range at 800 to 1500 on volume. And I let the therapist work with the patient to see the volume that you're most comfortable with. So anywhere between 700 and 14 or 1500. It's up to the patient. You know, you treat the patient, not numbers. You try the range that I set and you decide what you like. Because remember, you got to use that air not only for deep breaths, for tidal breathing, but also for lung volume recruitment, for air stacking. So the higher the volume, the faster you can air stack, and the better, you see. So now, some patients on volume ventilation, when they sleep at night, if they close their throat, the air goes into the belly. If abdominal distension becomes a horrendous problem, then I switch them to pressure. And I try to get the pressures below 25 centimeters of water, because that's the pressure that the valve between the esophagus and the stomach is good to. So in other words, if I set the ventilator at a pressure of 22, then the air should not go in the stomach, unless you have a hiatal hernia or other problems with that valve. But if I set the ventilator for a volume of 1,000, and you close your throat, that 1,000 will go into your stomach, okay? Mm-hmm. Now, the air passes when you get up in the morning, but for some people, if they have it every day, it's a big problem. So then I switch them to pressure. So, you know, I mean, this is, again, you got to treat the patient. But I would start with the volume, because I want the patient to do lung volume recruitment.
And what about the scenario if it's a child that doesn't really know?
Well, then I would use pressure, because a child cannot cooperate to air stack. There's no advantage of using a volume. Okay. So then you might as well use the pressure and try to keep the pressure below the integrity of what they call the gastroesophageal valve, the sphincter between the esophagus and the stomach, because you don't really want air to go in. Now, if a child has a gastrostomy tube, it's not a problem, because we just burp the air out of the stomach. We leave the gastrostomy tube open all night and burp the air out of the stomach when they're on nasal ventilation. Because, you know, they can have air going into the stomach, whether you use pressure or volume. It tends to be worse if you use a volume, but it can happen with pressure too, in which case you just burp the air out of the stomach.
Okay. You're asking about the cough assist from Nippy. It's called the Nippy Clearway, apparently.
Ah, yes. Oh, yes. Yes. Of course, it's the Clearway. Yeah, the Nippy Clearway. Oh, yeah. The people who work for that company are so sweet. I like them a lot. No, I like them a lot. I didn't want to, you know, hurt their feelings by forgetting the Clearway.
Good stuff. So a question, and I knew we wouldn't get away with it. Spinraza, Zolgensma, what impact is that having on respiratory care?
Well, they're having a lot of impact on the ventilation for the babies, but clearly it's worked so much better for children who get it just at birth or before 5 or 6 months of age. When it's given to older patients and adults, sometimes it does amazing things, and often it doesn't seem to do anything. Now, the reason I say that is because in Belgium, you know, the company that makes that stuff, Spinraza, for 3 countries in Europe, they gave free doses for 1 year. They didn't do that in the United States, only in Europe. So I had a couple of patients fly to Italy to get nusinersen for a year. And they couldn't get it in the United States because it cost $1 million. Mm-hmm. So there's a Dr. Laurent Servet in Liège in Belgium who treated 100 patients with this, including older people. And I asked him, how do you know when you're going to help somebody or not? He said, I have no idea, he said. He said, sometimes it helps older people, other times it doesn't seem to do anything. But what's clear is that the earlier you start it as a small baby, the better it does work. There's no doubt about that.
Okay.
The risdiplam is coming out, and the risdiplam seems to have equivalent outcomes to Spinraza. And of course, it's a lot easier to deliver because it'll just go right into the gastrostomy tube or by mouth. So there's really not much of a downside to risdiplam, it seems. It seems as safe as the other 2.
Yeah, fingers crossed. It's going through our regulatory process at the moment. So fingers crossed it will be available later on in the year. Another question, do you recommend using BiPAP vent with a humidifier or without?
First of all, I don't recommend using BiPAP. I hope I've made that clear. I do not use BiPAP. I do not use any EPAP. I use assist control volume or pressure on a Trilogy or an Astral or an LTV or a Newport or the Nippy. You know, you can use, Nippy is not available in the United States, but they have a ventilator too, and you can do this on their ventilator. So I do not use BiPAP. BiPAP is suboptimal. It can be used for third world countries like the United States has become. England, I think, is already there, right?
Yeah.
I got to be careful with you guys because, you know, your sense of humor may be somewhat different from mine. Not that I want to pick on England. Look, I can recite Winston Churchill. I know quotes of Winston Churchill that you probably never heard. I'll tell you one of my favorite. In my chapters in my book, Winston Churchill once said that a good lecture is like a woman's skirt. It covers the subject, but is short enough to keep the interest. So I'm using that as a quote in one of my chapters. Unfortunately, it's one of my longer chapters right now.
No worries.
But he had some great quotes, Winston Churchill. You know, I love Winston Churchill.
Yeah.
How did I get onto this? That's right. I'm worried about your sense of humor. Yeah. But,
no, don't worry. Yeah, don't worry about my sense of humor. As some will attest, it's certainly odd.
No, see, but the United States now, as of last year, had a government deficit of $23 trillion.
Yeah.
Now it's about 30 trillion. Now that's over $100,000 per American.
Yeah.
You may believe or not believe that we are born in original sin, but I guarantee you we are born in original debt by over $100,000 per American.
Yeah.
And if we had the same healthcare system as Singapore, we would save almost $2 trillion a year instead of being in the red by $1.5 trillion a year. But that's another story. You know, I did I'm an alumnus of the Rutgers Medical School. And every year they have the Rutgers University Alumni Lecture. A few weeks ago, I did a lecture and I discussed some of this stuff. So you can find that on the internet. And if you want to hear how the United States is run, and medical care in particular, you could listen to that lecture. But our medical system, we're rated 37th in the world by the World Health Organization, and we spend enormously more than anybody else, you know, 23% of our GDP. Singapore spends 1% of its GDP, is guaranteed healthcare for everybody, every citizen. They live 4 years longer, and they're rated 6th in the world.
Well, as someone that's worked in the NHS for 25 years, we certainly don't have it all right yet.
No, I used to think that the Canadian and European systems were better than ours. And you are better than ours. You are better, but you're not sustainable either. Because you can't afford to spend 9. You know, France spends 14% of its GDP for healthcare, and they're rated #1. But 14% is not sustainable. Singapore government spends 1. And they do a better job than we do.
I could argue for hours on this. I mean, I could say that the US healthcare system is probably one of the best in the world if you're rich.
No, but I'll tell you why. Richard Nixon was almost killed by experimental interventions because he was rich and famous. More people, I'll give you a classic example. About 15 years ago, for $1,000, anybody could get a total body CAT scan to detect cancers that you could cure before they metastasize and kill you. So my own colleagues, doctors I worked with, paid $1,000, got a total body CAT scan. It increased their cancer rates by 3%, and 90% of the lesions they found were incidentalomas. And more people were killed by evaluating for those benign lesions than were saved by finding something that could be found early. So if you have the money, you actually can get worse care.
I'm getting told off by the audience for dragging you off topic.
Yeah. I'm sorry. It's easy to drag me off topic. It's very easy.
So we were talking about humidifiers. Yes or no on?
No, humidification is strictly dependent on the patient. Now, when you get bronchitis, you cough up sputum. If the sputum, the consistency of your sputum makes it easy to cough out. If the sputum is too dry, it attaches to the mucous membrane and you need a lot greater flow. And then when the sputum comes off, it tears the membrane and you bleed. But if you over-humidify the sputum, you liquefy it and it coats the bronchi, and then you need an infinite flow to clear the liquid coating of the bronchus. So in other words, if you give too much humidification, you increase the secretions and you make it more difficult to clear. If you give too little humidification, you do the opposite. You tear your membranes, you desiccate the sputum. So first, remember, the nose is a humidifier. People who get nasal ventilation usually do not need any humidification. But there are exceptions. There are people who like humidity. But in general, because the nose is a humidifier, no, most people do not need humidification.
Okay, I've got another question right. Using a ventilator at night, will that not make a person dependent on it? They're a type 2.
No, just the opposite. If you use a ventilator and rest your muscles well, your blood gases will be better during the day. Your vital capacity will go up by 15%, which means that your diaphragm is actually stronger. You do not get dependent on a ventilator by using it overnight. In fact, you don't get dependent on it by using it day and night. You get dependent on it if you get trached. Because when patients get trached, they become totally dependent on the ventilator if they were using it day and night before and had some ventilator-free breathing ability.
Okay.
TreatSMAs and Duchenne patients, if they're using a vent at night and they use it a little bit during the day, once they get trached, most of them can never be free of the ventilation again, for many, many reasons, which I write about in my book. So no, you do not get more dependent on a ventilator by using it overnight. You actually get less dependent on it. By resting your muscles at night, you make your muscles stronger during the day, and your pulmonary parameters get better. Your vital capacity goes up.
Okay, I've got a message from a concerned parent. I'm going to hospital with my 3-month daughter to get the NIV set up by doctors. Right now, I'm not sure the doctors will set it up correctly. What should I pay attention to?
Well, you know, we don't put people in the hospital to set them up on non-invasive ventilation. We have an outpatient clinic and an expert respiratory therapist. I don't know what they're going to do. Now, in the United States, they send these kids for polysomnograms, which are completely useless. I don't think you do that in England, though. I don't think you do that. You should probably give them a copy of my article that says everybody with paradoxical breathing needs non-invasive ventilation. Excuse me. Now, I write in the article what the settings should be. They will look at those settings and say, wow, those are big settings. We don't do that here. But then you could say to them, yeah, but Dr. Bach has 25-year-olds who are 24-hour vent users since they're 4 months old, and none of them have trach tubes. And then they'll say, oh, that's not true. That can't be true. It can't be SMA type 1. And then you'll say, well, you know, look at his articles and his publications and his books. So that's likely what would happen. Now, that's assuming, of course, that the doctors are closed-minded, which is a very good assumption because most doctors are closed-minded everywhere. On the other hand, they might actually look at the article and say, what's the harm in using the settings that Dr. Bach uses? You know, like 18 and 0. They might be afraid of the lung blowing up. And then you can say, well, Dr. Bach has never had a patient. He's treated 3,100 patients this way and has never had anybody's lung blow up, you know. So you have to be lucky. You have to get a young physician who still has a relatively open mind and is still capable of learning something. The chances of that are relatively small. In the United States, very small, unfortunately. But in England, I don't know. I mean, I really don't know British doctors like I know American doctors. But in general, I know age, and the younger the doctor, the more likely he might take an interest in actually following up with what you're telling him.
Okay.
Again, you need a pressure of 18 and 0 to reverse the paradoxing. If the baby has SMA type 1, when the belly goes out, the chest sinks in and the lungs don't grow. So you explain that to the doctors. That's what the article says. Now, when the baby sleeps, with 18 and 0, the mother will see the chest expand with the belly. And that's what you need to see. Because that means you're resting your muscles, you're expanding your lungs, and the lungs will grow, and the baby's getting good rest at night. So that's the message. And if you send me an email, I'll send you a copy of the PECTUS article. And you can print it out and give it to the doctor. I'll send you 1 or 2 other articles too.
Do you want to send them?
Yeah, I'll send it to you.
If you send them to me, John, then, and you don't mind, do you mind us putting on our website for them people to download?
No, I don't mind personally, but you know, the journals say that you're not supposed to do that.
Oh, okay.
Because of copyright things, you know? I mean, I personally, I have no problem with that. But
Okay, well, what we'll do then is we'll probably share them in our closed Facebook group.
yeah. I'll send them to you, and then
Okay.
send them to whoever wants them.
Okay.
Yeah.
So if you're not part of the Facebook group, then drop me an email, Andy with an I, just to be different, andy.thornton@treatsma.uk. And
Well, I think I have your email, don't I? You
yeah,
send me.
no, I was just telling everybody else to drop
Oh,
me an
okay.
email, and we can forward.
Oh yeah, I'll send you some really good articles that
Right,
you
that'd be
really,
brilliant.
because I'll tell you, 2 of the articles are extubating unweanable babies with SMA type 1.
Okay.
Now, when a baby gets pneumonia and gets intubated, you've got to get an intensive care doctor to take an interest, and that's even more difficult.
Mm-hmm.
They just want to trick people and, you know, send them someplace else.
Okay. Right. We're going to crack through another couple of questions, but then we're going to call it a night, because otherwise we'll be here all night with you.
Well, I forget that. What time is it over there now?
It's 9:30. We're just coming up to 9:30.
Okay, 5 hours difference, right?
Right. So just a follow-up question on the humidifier. Can you ever over-humidify something?
Yeah, of course. Yeah,
So,
I told you, if you over-humidify it, then the sputum becomes liquid, and the liquid coats the bronchi, and you can't cough it out.
Okay.
Absolutely, the secretions will increase if you over-humidify.
Okay. Someone here has said ST or PC mode. I have no idea what that means.
That means a backup rate on the BiPAP, and PC is pressure control. Pressure control is generally done with an active circuit on the ventilator. That's what we use. For babies, we use pressure control on the Trilogy or an LTV or something like that, because we don't have any EPAP on pressure control. It's the ventilator mode, and it's not a BiPAP mode. Okay.
Another question: do you use oscillation mode in cough assist machines?
There are articles that have said that that doesn't make any difference, and in theory, I don't see why it should make any difference. So no, we have not been using that. But there are many articles that have studied it, and they come to the conclusion that it doesn't really make any difference. There was one article that suggested that one slight benefit from the oscillation. I don't remember what it was. I think Michelle Chatwin's article discussed that too. She said that there might be one very slight benefit, but most of the articles have suggested that there's really no particular, and I'll tell you why there's no benefit, because the oscillation and percussion and vibration go in resonance with the hairs in the lower lungs, okay? But people with SMA don't have any disease of their airways. Their problem is that they can't cough out the secretions in the central airways. So there's 27 divisions of the bronchi. The 21 peripheral divisions, the little hairs bring stuff up. But then when you get to the 6 central divisions, you've got to cough that out. Now, the cough assist works on those 6 divisions. The oscillation may work on the other 21 peripheral divisions with the hairs. But SMA patients have healthy lungs. So there's no theoretical reason why vibration, percussion, or oscillation should have any benefit at all on the peripheral airways of people with healthy airways. So that's the way I look at it. That's why I don't think there's any particular benefit. Okay, brilliant.
John, I don't quite know how to thank you enough, but it's 2.5 hours you've spent with us.
Yeah, unfortunately, I do have some things I got to do. I have something to do today.
No, that's absolutely fine. But I mean, seriously, the questions, the viewers, the comments that have come in have been amazing. So thank you for taking the time. What I would do, if it's okay with you, we'll go through the comments and questions that perhaps we haven't asked, and maybe I can email them to you.
Yeah, okay. Yeah.
All right.
But I think you'll find the answers on the website and on the articles too.
And just remind us, your website again is breathenvs.com.
Yeah, breathe, BREATHENVS.
Okay.
.com.
We'll put a link to that on our
Oh
website.
yeah, absolutely. Good idea. Very good. Yeah.
Thank you ever so much, John. Thank you, everybody, for joining us. And hopefully we'll get to speak to you again soon, John.
I hope so too, Andy.
All right, take care.
Right, bye-bye.
Bye-bye.